Hi, doctors. How are you? Welcome to our first session for the live sessions for this course. I'm really happy with your progress during the week. I see the pattern. Some people watch the video in the beginning, in the middle, but the pattern I love was like yesterday at night. Everyone was on the website trying to catch the material, stuff like this. And this is why I'm doing this live session because like the way I think about it is like if I give you material and I leave you with no follow up, sometimes you gonna be late about it. So this is why I love to make it like live session to connect everyone together also and to go through material. I will go now chapter by chapter to hear what do you think. If you feel something is not very clear, so I will explain it again and I will see your question. We discuss it together, and then finally we are going through the quiz I make and the like 10 question at the end, so we make sure everyone on the same page. Some of you asked me for a WhatsApp group to communicate together, which fine with me. Yeah, I will do the WhatsApp group today. I will send you the link on the website so you can join. Okay. Okay, so before we start, anyone has any question or would like to add something? Okay, doctors, can you hear me? Hello. Nice. Okay, good. Okay, nice. Okay, so in this week we start with the first 4 chapters from pharmacology. We start with pharmacokinetics dynamics, and this tag is extremely important now, and it will become important as the time goes, because like when time go and you would like to recap or restudy pharma, you need to know about this one. So basic, like as we mentioned, like it's like basic stuff like you must know for yourself to make the other cardiovascular and CNS easier for you. And important means like before the exam you should try to study it again. If you see auxiliary mean you study once or twice. This is not very important for you. I would like just to know like maybe 2 or 3 information about it. And when you see critical means you have to study it now at least one time before the exam and before the exam. So critical at least 3 times before going to your exam. Okay. And then we discuss about dynamics, kinetics, and I don't want the second lecture to be like explaining everything again. I will just go through it, and if you see anything like would you like me to explain it again, feel free to ask me. And as we discuss, maybe we can do the one-to-one session, because some people would like to ask like in private, so no problem, we're gonna do one-to-one session with each one of you to address your concern. From this one, I would like you to know this routes of administration. We discussed the oral to be the most common one because it's easiest, but like it has a lot of side downside, like this first path metabolism, and it take longer time. IV to be for the emergency, sublingual inhalation for emergency, rectal when patient is vomiting or the medication itself induce vomiting, subcutaneous or intradermal for like the medication which will be absorbed in the GIT, like insulin, and we need longer time. The outlier information here in the oral, we have some medication which end up by almost 100% bioavailability inside your body, which is, I hope some of you remember this one. Yes, I will give you a few seconds, then I will say it. It was metronidazole, and then we ended up by one more in antibiotic. I will not say it. Maybe we can, some of you can remember it. So, and then at the end, I love to do this way. So after you study this part of the chapter, this is like recap everything about the chapter. So before you move from this part to the next part, I would like you to understand this one. Okay. So this is from here, and then there is some this one like bioavailability, some terms which is like most likely not to be used in clinical aspect, but like you should know about it, because like bioavailability, you remember we discussed about the medication coming IV to be 100% and the other not to be 100%. So how come they know how much it is? Because like once the medication goes inside your body, clearance will start immediately. So there is equation about it, and you don't need to know about it because we are not a pharmacist. Everyone here is a dentist, so we don't need to know about this stuff. And then we discuss about solubility, first pass metabolism, and we start about blood flow. Here, yes, I would like to discuss about this one. Volume of distribution. Again, volume of distribution is very critical to know about it exactly. But as you remember from the example I told you about the man inside a mall, and he would like to know how much people like in each floor. So this is the same situation we have here. We cannot go inside the tissue. We can see only in the blood level. So we're going to estimate how much inside the blood level, how much inside the tissue. So we're going to do this equation. Again, this not for yourself to study it in depth because sometimes people ask about this type of terminology. Just know it and move. Don't waste much time study about this one. And finally, we discuss about this one, which is extremely important. This is really important, and it will become important as you go through the chapters about the phase one and phase two. Most drug goes through phase one, which is oxidation, hydrolysis, and then go to phase two, which is conjugation. Conjugation make the drug inactive. So when it become inactive, it will be secreted outside the body through kidney, skin, and lung. And this is the problem. And then we discuss about this scary family 450. Why this is scary? Because this is the enzyme will break down the drug. So most of the drug, it goes inside your body as active. But some drugs will go to be inactive and it will be activated by this one. And some drug will go to be active, and then with the medication, with the working of this enzyme over it, to give active more metabolism, active like substance which is more active than the primary drug. So this is, I would like not to confuse you. So the mainstream, the drug will go active, and then the liver one work over it to deal with it, and then which will go to phase two to be inactive and then excreted. Some medication, maybe 4 or 5 in our scope as a dentist, will go to different. It will be inactive and then activated, or be active to be more active. But don't like think about it too much because it's few drugs. And when we go to these drugs, I will tell you about them. Okay. So from this one, the information I would like you to know: phase one, oxidation hydrolysis, and phase two, conjugation. Phase two make it inactive to be excreted from the kidney. Okay. And then we move through the kidney itself, the elimination, how does it happen, the process itself. I know I explained it in depth because like when we go to diuretics, you will know it more. So what I found really beneficial of my study, I hope I receive feedback from you, because like when you study about diuretics, I'm telling you this is like to compete with elimination from this part of the kidney, or this is to compete with filtration from this part of the kidney. Sometimes you get confused because you don't know the mechanism about it. Where does it happen in the kidney or in the nephron specifically? So this is why in these chapters, in the basic chapters, I will invest more time to explain about it, because when you go to the next chapter in the diuretics, I hope it will be easier, not to be like memorizing this one and memorizing this one. Okay. But anyway, here that it's very simple mechanism. So the blood come, let's go to this one. So the blood come here with waste in the artery, go inside the kidney. The kidney act as a filtration through the nephron. In the nephron, we have more than one part of the nephron itself. So we have ascending and descending and ascending and collecting. So some active transportation happen in the first part, which we call absorption, and then in the next two part loop, the descending and ascending, some transportation happen again, and in collecting, and the name like can explain, it collect the stuff. So we are going to interfere as diuretics over this mechanism. Sometimes we are going to interfere in collecting duct, sometimes we are going to interfere in the first one, and then the mechanism of interference will give us idea about how potent the drugs are. Okay. And then steady state kinetics. So every time you give a medication, it will be cleared. So we need to reach like a steady level of the concentration of the drug inside your body. So we need to know the half-life. This half-life is important. Why they ask, and they will ask you in a clinical way of asking. So they will tell you mother is lactating and she is taking medication which is cannot be taken during lactation, but she has to take it like antibiotic, and she has to take it. So when she can feed her son or her baby after taking the medication, and then he will give you the half-life. So sometimes he give you the half-life and make you do the calculation, but sometimes he asking you what is the minimum time. So the minimum time 3.3. 3.3 half-life is the minimum time, because at this time it will be 90% cleared outside of your body, but the optimum time to be 4 times. So when you see the number 3 and 4, so you will gonna pick 4, because there was a question about it. So because you see here about 4 to 5, because we don't want to risk it, because like some medication is really dangerous, like tetracycline, it will lead to discoloration. Codeine or morphine, it will lead to our baby to be happy baby, maybe get to respiratory depression. So this kind of medication is extremely dangerous, because if you think about it, by this way of thinking, we are going to let the mom wait every time after each medication, to wait at least 4 times. We are not going to do this, because not all the medication go through the placenta, go through the milk to go to the baby. But like this is the way they are going to ask. Most likely they are not going to ask you theoretical question, they will give you as clinical question. Okay. And some medication it will stay for a long time. This is why some antibiotics, some antifungal, you take only one pill the whole day. Okay. And then we discuss about this ligand gated G protein enzyme linking intracellular. So all the medication, not all, most likely the medication will act extracellular. It will act here to send a signal. The signal goes inside, and then it will act. Like the steroids and some little medication will go inside the cells. Okay. And the most commonly, like we discussed, this one to be the fastest within milliseconds, this one to be seconds, this one maybe take to like maybe hours, and then this one takes up to days. Okay. Okay. And then what else is important? I would like you to know this one. Yes, agonist antagonist. So how the medication work, you remember the previous diagram, here we have it. So we have receptors and we have medication. So sometimes we act to be agonist, sometimes act to be antagonist. Agonist mean mimic. I would like you to know then this different wording of the same concept. Agonist, mimic, act like. So this is the way you know this medication is doing the same action as the neurotransmitter, like acetylcholine. When we give medication which is agonist, so it will act by the same. But there is two factors to let us know if it's full agonist or partial agonist. And this is tricky, so I would like you to pay attention here. So some medication, even at the maximum dose, like the dose, like we cannot go beyond it, it will be partial agonist. Means when it goes to occupy all the receptors, it will not give the same degree or the same strength of the potent drug, the first drug. So we are going to call this one partial agonist. But some medication, even when it occupy 3-4 receptors, like minimal receptors, it will elicit the same maximum response. So this one is called full agonist. So full or partial is not related to the amount of drug. It's related to different factor, which is potency and affinity of the drug to receptors. So even this partial agonist, if we increase the dose to be maximum, it will stay as a partial agonist. It's by itself is a partial agonist. But the other one, even we have little dose, because it has different mechanism, potency and efficacy, or the ability of the drug to bind to the receptors and elicit the response, so it will be full agonist. And then in the antagonist, we have two ways. We have antagonist to just occupy the receptors and prevent the neurotransmitter to come into receptors. Some medication will occupy the receptors competitively, meaning like if it will go see neurotransmitter, so sometimes it compete with it over the receptors. So for this one, we're going to call it competitive antagonist. Some other medication will compete it irreversibly, mean it will go to receptor, make covalent bond or make like whatever bond with the receptor itself to stay over it. So this is why we call it in a way irreversible. Like irreversible, like when you think about it, it's like forever. No, irreversible here mean it will occupy the receptor for long time. So whatever we are going to see neurotransmitter, it will not be working. And finally, we have antagonist to work in a different level. So it will let the agonist go here, or let the neurotransmitter come here, and then it will cut the signal from a different aspect. So this is antagonist, but like it's working in a different mechanism. This is important because this is really important part in this chapter, because all the medication coming in the CNS cardiovascular, you will see this word agonist, antagonist, competitive, non-competitive, reversible, irreversible. So I would like you to know, because sometimes you ask you flumazenil is like, and you see in the option competitive, non-competitive, reversible, irreversible. So you should know which one is it. Okay. Yeah, so this one agonist, antagonist, and finally we have one more mechanism, which this is allosteric, which is mean it's going to bind a different location. One more, it's functional. Yeah, this one, functional antagonist. Functional antagonist means we are going to work over a different, completely different receptor. So, for example, is a functional antagonist by epinephrine to histamine. Epinephrine is working in a totally different one. Histamine is working like over H1 receptor in the bronchus path, and epinephrine is working over beta 2. So epinephrine, it will lead to action inside your body which functionally antagonize the histamine. So it's not related to the histamine receptor, it's not related to combative, non-combative. Functional antagonism is like we are going to do give a medication which act against the function of the other medication. Finally, we have this one. I would like you to remember. So every time you study a part of the chapter, you go to recap this way and then move on. Okay. Finally, we have therapeutic index. Again, this is like this theoretical. Even if you ask a pharmacist, all this term is a theoretical term. They don't use it in real life that frequently, but like this is important from the clinical aspect, because you need to know about this what we call like narrow therapeutic index and wide therapeutic index. Penicillin is the golden example of this one. It's a good antibiotic. It has wide therapeutic index. Therapeutic index mean like if a dose is one tablet, and by chance or by mistake you take two tablets, or sometimes you see people like he's in pain and he think if I take double the dose, or if I take the dose every 2 hours, it will come with more benefit. For penicillin we are good, but like some other medication like warfarin, lithium, digoxin is extremely dangerous. It will lead to extreme side effect. Okay. Okay, so that was everything for first chapter. Before we move to the second chapter, do you have any question from this one?
No, doctor, everything looks good. No, no.
Good. Okay, and one more thing I would like to hear from your life. During the explanation or during the video, I do a recap after like each part at the end. Do you like this way or you think it's boring?
Oh, it's perfect. Keep it going, doctor.
Good. It's not boring for some of you.
No, no, because we like recap again, like, and we follow you, like we open the same page again and follow up with the same scheme. Yeah.
Nice. Okay. Good. Good. And one last question. Good. Nice. Right. Yes. Anyway, in the video itself, did you catch the tags here? I have tags. This green little shape in the beneath in the bar at the bottom of the screen. You can just click it and go through it. And after you finish the video itself, I did the question to be like in a question myself. And one more thing about the questions. The question I'm giving to you is like what they call exam grade questions. What this mean? So this question, it's not a secret. This question I collected from textbook. I don't go to like because I hate it this way, because I see some people like inventing questions. So I don't think I have enough science to invent questions. So whatever question I'm giving to you is just from textbook. I go say a textbook, go through it, and then there is some extra reference in the textbook with questions. So I give you questions. And trust me, this question, as I said, like it's exam grade question. So don't feel bad when you miss the questions. I would like you from day one to have this question. And if you would like to go with what they call like the practice question, which is the release question, I have a folder in Quizlet with all the question. Do you have access to this Quizlet folder? I don't think so. No, you don't have.
No, we don't have.
So I will post the link on the website, and then please request access. I will give you access. But again, these questions is not like it's very old question, but like some people ask about it, you go through it. But the question I give it to you on the website, this is what we call exam grade question. Okay.
Okay, doctor. Is it the same like the way that you have explained if it's correct answer or wrong answer, or
Not all, because it's like almost 3,000 question. Not every question I will have explanation about it, but you will see it. Yes. It's yeah. I know. This is why I tend to say it now for everyone. Yes, it's difficult question. Don't feel like this easy question. No, it's difficult question because I would like you to be alert because like I think about it this way. Um, you are going to study for the AFK exam, which is 200 question, difficult question coming in 4 hours. So starting from day one, I'm trying with you to build the stamina. So you see in the video you have 4 question, 5 question. By the weekend you have 10 question. As we go through, I will increase those to be 15 question, 20 question. So when you go like by November, December, you know how to solve questions. So you are in shape. You don't like go because like honestly, when you solve the practice question, you feel oh it's easy question. So why people think about this exam to be difficult? Because like Korea's question is so easy question, but this question is not easy. Okay. So moving on to next chapter, which is like adrenergic and cholinergic, which is critical. This chapter is critical because all the medication you see here, we're going to apply it in the CNS chapter, and CNS chapter is really important. It used to be like auxiliary before, but like in the last cycle and the cycle before, they ask questions from the chapter. So please, you need to know about it. Okay. So we have two systems like central nervous system, peripheral nervous system, but like anyway, we are going to skip to this one. So we have in central nervous system we have what we call preganglionic and postganglionic and ganglia in between. Why we have this system? Because this system is like acting as a brake and a firing system to fire this type of organ or to break this type of organ. And we have two system working over it, which is sympathetic and parasympathetic. Sympathetic, think about it, fight or flight. Parasympathetic is rest and digest. So any medication I'm going to give to you to be agonist for sympathetic, so it will make everything fire in your body. It will like get your lung to work harder. It will make your heart pump harder. It will inhibit the stomach movement. It will inhibit stuff in the stomach. It will induce your body to get glycogen and insulin to be inside your body. In parasympathetic, after the fight is done and you rest now, so in your rest and digest, so the stomach digest will be more, the intestine digest, like movement of intestine will be more, and salivation will be more, airway constrict and the pupil constrict, because you don't need to get more light to see further. Okay, so this is the main mechanism. And more difference about this slide is nice also. 1 second, let me zoom out. So in parasympathetic, there is longer preganglionic, shorter postganglionic. So this type of question sometimes they ask it. So longer preganglionic and parasympathetic, shorter postganglionic. Here is a difference, the other way around. And one more difference. All the preganglionic, sympathetic or parasympathetic, it will come from neurotransmitter which is act acetylcholine. Acetylcholine will act on both sympathetic, parasympathetic, preganglionic, and postganglionic, sympathetic. It will be epinephrine and norepinephrine. Okay, and then it will go to the target organ. Okay, and here's like whatever we're going to discuss for the next few chapters. This is the synapse. So we have neurotransmitter coming into vesicles. This vesicles will rupture in the synaptic gap, and this neurotransmitter will come into receptors, and then it will give impulse. So if I wanna mimic it to be agonist, so I will encourage this vesicles to release, and then I will act upon the enzyme which is breaking this and the neurotransmitter like COMT will break epinephrine and norepinephrine, and acetylcholine esterase COMT MAO, sorry, yes, MAO will break that, yes, and acetylcholine esterase will break down acetylcholine. So if I want to make it mimic, so I will inhibit the action of these enzymes, or sometimes I will act over the receptors to be agonist, to work over the receptors to make it act like it's acetylcholine. So this is the way of mimicking, acting in favor of this one. And antagonist, either I will inhibit the neurotransmitter release, or I will encourage the enzyme to break down the acetylcholine to break it faster, or I will block the receptors. This is the way of thinking for all the medication. As we discussed, like you didn't see the CNS. The problem with CNS is that for antibiotic, you watch antibiotic, yes. For antibiotics, not even this. For analgesics, for example, analgesics, we know this medication is working over COX-1, COX-2. So we know the side effect of it. We know how to deal with this one. We know which patient to give this medication. When you go to CNS, it's a huge area of gray zone. We don't know which medication is working, which transmitter is related to this condition. So you will see a lot of side effect coming from CNS receptor. Okay?
Excuse me, doctor.
Yes.
I have a question.
Yes.
About the synapse. If we are talking about alpha 2 agonist,
Yes.
can we consider it as a reversible agonist? Because it's what it do is it's blocking, but it's still like it's work an agonist.
Yes, alpha 2 agonist
Can we
is
consider it as reversible, or can we take it as an example?
okay. So I know what you're asking. So let me go to the slide for this
Because
one.
alpha 2 gonna block like the reabsorption of the epinephrine to go back to the vesicle. So that way it's gonna reduce the
Blood pressure.
sympathetic effect.
Yes. Yes. Okay, let me explain about this one because I know this is tricky and this is why I have a question about it in the questions. Okay.
What I'm asking is about the antagonist effect because, as you said before, we were talking about the competitive and non-competitive, and there is a term about irreversible or reversible antagonist, reversible agonist.
Yes.
Which is work as an agonist, but it's reversed the action of.
Got you. Yes, got you. No, no. Yeah, understand.
What I mean.
No, no. Okay, so
Can we apply this for alpha 2?
no, no, we cannot apply to alpha 2 because I understand what you mean. So I think let me rephrase the question to confirm I got it correctly. So we know all adrenergic agonists to be firing over the heart, so it will lead to ionotropic, chronotropic, and increase the blood pressure. But when we go to alpha 2, we have medication which name is clonidine, which act agonist for alpha 2. It will lead to reduced blood pressure. Correct?
Yeah.
So you think about it to be
The term is called reversible agonist.
no, here it's not reversible agonist. Yeah, I understand you what you mean. No, here it's not reverse. So let's go 2 step back to confirm this reversible irreversible. So reversible mean like this. You have acetylcholine working over the receptors. Okay? So when you give a medication to be agonist, so it will this medication, like give it name A. This medication A will go to compete against acetylcholine to occupy the receptors. So this mechanism we call it reversible because there is a competition between both. But irreversible mean like other medication.
It's gonna depend on the amount of if the amount of if we have higher level of let's say acetylcholine,
Yes.
it's gonna be like it's gonna block. If
Yes.
we have lesser, I got it. I got this one.
So it's not related to this one. I understand. So you mean like a clonidine will be reversible? No, it's not reversible because it's acting in different mechanisms. Clonidine is going to fire this alpha 2 to be agonist for alpha 2, but like
Yeah, it's gonna affect. It's gonna give effect on alpha 2.
Yes.
But it's gonna block alpha 1.
No, clonidine is like working over alpha 2 only.
Alpha 2 is gonna block alpha 1.
It's not.
It will reduce. It's gonna give dilation for the blood.
Yes.
For the blood.
Yes.
It acts.
Yes.
It acts opposite to alpha 1.
Yes, it acts opposite.
That's why. That's what I mean. Like
yeah.
Clonidine. We take clonidine for hypertension. Right?
Yes. Correct.
So when we activate this receptor, it's gonna be irreversible because even though if it's an agonist, but its action is irreversible, so it's gonna reverse it's gonna block the action of alpha 1.
Okay, I understand your point now. Yeah, let me search about it and get back to you. But like usually, I'm just explaining the mechanism for you to understand. But this reversible, irreversible, like it should be mentioned. So it should be mentioned. This one act reversible, irreversible. But like this is makes sense because like this is the way of acting. So let me explain this one because it's like it was confusing for me for very long time till I.
It's gonna be mentioned in the question.
Which one?
The irreversibility.
It will ask you this agonist is reversible. It give you in the option reversible agonist, irreversible agonist. So you should know about the medication when you read it, when you study this medication agonist. It will be irreversible or reversible agonist. That's it.
Okay.
So the question will ask you this agonist is A irreversible, B reversible, C comparative, D functional. So when you read the option, you should understand it.
Okay.
Okay. So let me explain this one because it's a little tricky, but once you understand it now, it will make it easier. So we have four type of receptors in adrenergic. We have alpha and beta. Alpha, we have alpha 1, alpha 2, beta 1, beta 2. And this is the way of acting in everything inside our body. We have what I call circle of life. So every system has its break inside it. So meaning alpha 1 is leading to vasoconstriction, increase in peripheral resistance, increase in blood pressure, increase in closure of bladder sphincter. At the same time, most of the medication act as agonists for adrenergic. It will act over alpha 1, alpha 2. Most of the medication act over alpha 1, alpha 2. Alpha 2, if you read with me, inhibit norepinephrine release, inhibit acetylcholine release, inhibit insulin release, which in a way this one is acting against the alpha 1. So why this happens? This happens because every system should have its inherited break, because if you don't have this inherited break, your body will act over it, which is going to be what we call reflex tachycardia or reflex bradycardia. So the same mechanism by itself, it will act over alpha 1 and alpha 2 to give this one. And this is why you remember we speak about prazosin to be selective alpha 1. It will lead to severe hypotension, because like this is why we titrate the dose. We give the patient the dose and then we increase the dose till we make sure it's good. But like other medication working over alpha 1, alpha 2 by itself, it will like inhibit it, not inhibit it, break it. I don't like to use word inhibit, but like break it in a way. Moreover, whatever Dr. Muhammad is speaking about, like alpha 2. So, from your study, you will see almost always all the medication act agonist for adrenergic. It will increase blood pressure, except this weird medication which is clonidine. Clonidine is selective for alpha 2. So, we have prazosin selective for alpha 1, and we have clonidine selective for alpha 2. So, when we act agonist to mimic alpha 2, it will lead to reduction in the blood pressure. This medication not to be used in clinical real life, but like this is like tricky because you see adrenergic agonist and it's used to treat hypertension, which should be the other way. And for beta, we have some of conflict. As you remember, you have one heart, so beta 1 for your heart, and you have two lung, beta 2 for your lung. Why this is important? Because you see some medication, it will be non-selective, acting over beta 1 and beta 2, so it will be contraindicated for some patients. Like propranolol cannot be used for asthmatic and COPD patient because it's acting over beta 2. So in this way, we are going to give selective beta 1. At the end, there is medication which is selective for alpha 1, selective for alpha and beta, and there is a medication most likely we're gonna use, which is carvedilol, which is acting both over these both two medication. It has different mechanism of acting over it, so it will lead to maximum benefit of controlling the hypertension with the least side effect. Okay, and then we discuss about selectivity. Selectivity mean when I'm speaking about selectivity, this does not mean that like alpha 1 in blood vessel. This does not mean blood vessel have no alpha 2. No, it's like in pharma, it's a gray zone. Every receptor is happening everywhere, but like they found the affinity of alpha 1 to be happening more in blood vessel. Same for beta. Beta 1, they found it to be more over the heart. Beta 2, they found it to be more over the lung. But this does not mean there is no beta 1 on the lung. But they found the affinity or the condensity or like the percentage of receptors in this major organ is more. Why this is important? Because like when you see the medication is working over alpha 1 or alpha 2, so at least you have a feedback or idea where does it work. So when you understand this slide, also here, eye has alpha 1 and beta, salivary gland alpha 2 and beta 2, heart has beta 1, lung has beta 2. So then you understand the way of acting, okay? And then we discuss about the medication. We discuss about epinephrine and norepinephrine and the difference between both. Epinephrine working over 4, norepinephrine is not working over beta 2. This is why we don't use norepinephrine in the management of asthma or in the management of anaphylactic shock. And then we move till we reach to this one, like ephedrine and no, yes. Let me go to the slide here. Salmeterol, yes, and then yes. This is discussed at the end. Okay. Okay, so one more information here about cocaine. Cocaine is considered to be LA. This was very weird for me, but like cocaine considered to be LA, like local anesthetic, because it's blocking the sodium chlorine channel. For sure, we are not going to use cocaine as LA in the clinic, but like in the fundamental way of thinking, it's an LA because this is working here. And cocaine is extremely dangerous because how does it work? It's blocking the collecting of the, they call it catecholamine or the neurotransmitter from the synapse. So when we block the collection of it inside the presynaptic way in the presynaptic neuron, so it will lead to prolonged action of norepinephrine, epinephrine over your postganglionic. So in this patient, if you give him even small dose of epinephrine in LA, he might end up by hypertension crisis. So this is why we are going to avoid it. Okay, ephedrine, pseudoephedrine. Okay, so again at the end we have this slide to recap everything. This is a slide I would like to study every time. So sometimes you think about, okay, so just give me this slide and save me time, which I used to do for a very long time. At the end of the day, if you just trying to memorize all this stuff, you will memorize it for maybe a few days and then it will be gone because you don't know the background of the working of the mechanism of the medication or the receptors. Once you understand it, I'm not saying it will not be forgotten. It will be forgotten, but the frequency will be less and you have more understanding about it. Okay? And then we moved over to the antagonist. So antagonist, we have alpha blocker, beta blocker, and then the antagonist will be like selective to be alpha 1, alpha 2, or beta 1, beta 2. And then we have this mix that I told you about to be working over alpha and beta at the same time. And this is the most commonly used one because it has good mechanism of action and less side effect. And the non-selective, so some mnemonic for you to remember. All, not I will not say all, but like most likely the medication end by olol. It will be non-selective beta blocker. Propranolol is one of the most most frequently used medication here in Canada. And then we have non-selective beta blocker to be starting from A till N. But like you will see some outlier information about it, but like you start from A till N and end up by olol. So this one will be selective beta blocker to working over one beta only. And then the alpha blocker, we have selective alpha. We discussed about Zosyn to be selective alpha. And we said like this medication will have very strong effect to be against hypertension. This is why we don't use it or use it with caution with our patient. And then we have alpha 2 blocker, which is yohimbine. Alpha 2 blocker, we don't use it. This medication is not to be used, but like I'm telling you the name because you might see it in the question. And then non-selective, like phentolamine, is used. Like phentolamine is used to reverse the LA action when we want to reverse the effect of LA for our patient. I don't know a clinical scenario when we would like to reverse the action of LA, but like this question was asked a few cycles ago. Okay, so I'm giving you this mnemonic because like it's easier for you to remember. So olol is beta blocker. From A to N to be selective, after this to be non-selective, and Zosyn to be alpha 1 blocker. Okay? Okay, so this is everything from this slides. Finally, there is, I would like to discuss. Yes, propranolol is very important medication because propranolol is used for hypertension, it's used for arrhythmia, it's used for patient with anxiety. Most likely it will be part of regimen to be used with patient with congestive heart failure. Mostly all the cardiovascular condition, we're going to use this medication. But it has very bad effect over the beta 2 receptors. So this is why we don't use it with patient with asthma and COPD. In this type of patient, we are going to use selective beta blocker, which is will be beta blocker starting from A till N. Okay, acetylol to be selective. So here's like here I come to know this mnemonic. So selective A C N M. So this is the why I told you it's not very like accurate one because M start as M but like it's still as a selective one and non-selective coming from the other side and N in the non-selective one. So this is why it's not very accurate one. But at least if you forgot about the name of medication, at least you have something to think about it. And then this is the carvedilol and leptilol. So you see here, lol, this start by ILOL. So slit or ALOL. So this one is non-selective beta blocker with concurrent alpha 1 blocking action. So it will act over alpha 1, beta 2. So this way it has wide therapeutic index and it will have less side effect for your patient. Okay, this is why most likely you will see this one to be used here. It's working over alpha 1 receptor and beta 1 receptor. Okay, again we have here something to recap everything about it, and then I make this one. So in my brain I start to construct this note.
Excuse me.
Yes.
When it's non-selective, it has more side effect, right?
Yes, specifically with asthma and COPD. Okay. Okay. So I tried to make the medication, each medication to have a paper like a page for itself. At the end, I will make like for you index for pharma. Index of pharma mean like I will give you PDF chapter. This PDF chapter will have only this medication, like this page. It will not include the mechanism of action, everything. I will give you only the page of medication. Why this one will be like beneficial for you? Because before your exam, you would like to search for this medication only. Guanethidine, because this is a type of medication usually you will study now and forget about it later, and you will see in the question and you will, what, I don't know anything about this medication. So you will go to this PDF file, control F, you find the medication, and that's it. So this index will be easier for you to memorize. And also in the Quizlet set, I will give you a flashcard set which has the medication. On the other side, it has like Riserbrine is acting this way. It has this side effect. Like it's a few words about it for you to remember. Okay. Okay, and we moved for cholinergic drug. We have mimic, agonist, and antagonist, and then we have direct acting, indirect acting. Direct acting mean the medication is working over the receptors, so it has affinity for receptor to bind to receptor and work over it. Indirect acting, it will work over the acetylcholine esterase to inhibit it. And this is the reversible, irreversible. Again, irreversible here does not mean it will be forever. It means this type of medication, ecothiopate, specifically like ecothiopate, because this is like it's used for like eye condition. It will have longer time. So you give 1 or 2 drop for 1 week, and it's working for your patient for 1 week. This is mean it will be active for a very long time because in a way it's irreversible. Reversible, as we said, it will compete against it, so it will have longer, shorter duration, like neostigmine, physostigmine, rivastigmine, donazepam, and galantamine. So what you need to know from this one, you need to know the indication for each medication, because sometimes asking you about the when we are going to use this one. Receptor, here we discuss about the adrenergic to be alpha 1, alpha 2, beta 1, beta 2. Here we have beta 1, beta 2. Beta 3 is not very important. Beta 3 is used for adipose, like fat tissue. We don't have medication to discuss about it that much, but like I would like you to know about it. Usually we're discussing about beta 1 and beta 2. And here the medication cholinergic, anticholinergic, for you to understand the difference between both. Okay, and we move on to discuss about the medication acetylcholine, not to be a medication, it's neurotransmitter by itself. Okay, one more theme about the cholinergic drugs. Because cholinergic drugs is working over acetylcholine. Acetylcholine is a neurotransmitter in both sympathetic and parasympathetic. So you will see most likely the medication acting over it to be topical, like in eye. Sometimes it's like ointment. Why? Because if you give something is like manipulating the acetylcholine. So in this way, you are going to manipulate both sympathetic and parasympathetic. So when we want to use it, most likely we are going to use it in a topical formulation to like reduce the side effect over everything inside your body. Okay. And then each medication we have something to for you to understand. And then one more information here I would like you to know. Okay, so it's not here, it's not here yet. Okay. Okay. And then we move on to discuss about the muscarinic antagonist. So muscarinic antagonist, as you can see here, either we are going to block it or we are going to work acetylcholine. Okay. So we have atropine, cyclobentlate, scopolamine, and ipratropium. So each medication, again, I would like you to understand one or two information about it and you move from it. So this one, I would like, yes, this one. So I explained it in the video, but like I would like to explain it again here. So we have two system, parasympathetic and parasympathetic, working over your eye. And we have more than one muscle, but we have sphincter muscle, which as you see, act as like a circle over your eye. And we have radial muscle, which act this way. So when you have sympathetic nerve, mimic, you have fight or flight condition. So the action will be working over radial muscle for this muscle to contract. And then when you hear contract of a muscle, so you will think it will be acting to the meiosis because it's a muscle contracting, but it's the other way around. And this is so confusing till you see this picture. So you have a muscle contracting and this muscle is acting this way. So contraction of a radial muscle inside your eye by a sympathetic will end to mydriasis. And the other way in the parasympathetic. Because the muscle we are going to contract is a sphincter. It's like acting in circle. So when this muscle is contracting, it will lead to meiosis, not mydriasis. Okay? So this was confusing also till you see this picture. So because like you think a muscle contracting in the eye, so it will lead to meiosis. It will like make it narrower. No, because the muscle is a radial in action, it will lead to mydriasis. Okay? Okay. Scopolamine is like nausea and vomiting, and this is like one more information, clinical information. Usually scopolamine is used when it's beneficial when it's used before. Means like before you go to airplane or before you go to the Nile cruise you are going to do. If you take a scopolamine before, it will be beneficial and working. If you take it while you are vomiting, it not will be like very beneficial for you. More information here, scopolamine is contraindicated in angle closure glaucoma and should be used with caution in patients with open angle glaucoma. So let's discuss about this glaucoma because like without a picture, it will be very difficult to understand. Glaucoma is not here. Yeah, here. Okay. So what the meaning of glaucoma? So inside your eye, there is pressure coming from the liquid coming here. There was one more picture, which is, yes, this one. Yes. So here is the normal condition. In normal condition, we have fluid inside our eye. And then we have this one, which we are going to zoom in here. Okay, so we have this angle. This angle is preventing the liquid from inside your eye to come outside. Why this is important? Because if the liquid come from here till here, so it will get like end up by a fog or cloudy stuff in front of your eye, so your patient cannot see. Okay, this is in simple term. So they call this, the mechanism I told you now, is a cataract. Meaning like this is a cloud, or this cloud coming from the liquid coming from beneath, like behind your yes, behind, yes, from inside your eye to come here. So this one they call it angle. Okay, so glaucoma mean increase in the intraocular pressure. Excuse me.
It will block the lens.
Yes, block the lens. Yes, sorry, yeah, block the lens. So when the liquid come from here till here, it will block the lens. Nice. So we have a patient with glaucoma. Glaucoma means increase in the intraocular pressure. So if this patient has glaucoma and he has open angle here, so it will end up by a fluid coming in front of the lens, which we call cataract. So how we are going to like give a medication for our patient? So we are going to give him medication to relax this pressure, to get like to lead to more drainage of the liquid from beneath the lens, to reduce the chances of the liquid coming in front of the lens. Okay, Sometimes we have patient with open angle glaucoma, mean there is like, let me zoom in here. We means we have this angle to be open, so he has more chances of a medication coming from here till here. And we have some patients sometimes with closed angle glaucoma, so the angle here is closed, so whatever there is increase in the blood and the pressure inside your eye, most likely it will not come in front of your eye. That's it. This is what you need to know about it. I don't want you to understand more. So some medication will be contraindicated for open angle glaucoma. Some medication will be contraindicated for closed angle glaucoma. What you need to know as a dentist for AFK exam, these two information only, and this is sphincter and radial muscle for you to understand, and that's it. If you want to understand more about it, maybe into one-to-one session, I will discuss more. Because I see when we explain more information about a topic which is not very important, it confuses the other dentist. So this is the information I would like you to know, and I would like you to visualize it, because when you visualize it, it's easy. So what the meaning of open angle glaucoma? It has more chances to end up by cataract. Or closed angle glaucoma, it has less chances. Why? No one knows. It's anatomy of the eye. Sometimes it's open, sometimes closed. How we are going to deal with it? If we have open angle, some medication contraindicated. If we have closed angle, some medication will be contraindicated. That's it. Okay?
Both are like normal. It's just differentiation between individuals, right?
Say it again, sorry?
Like open and closed are normal. It's just like different individual differences, right?
Yes, it's not like pathological
They
condition,
are
yes.
normal both. Yeah, it's not something pathological or something.
Yes, no. Some people have open angle glaucoma, some people has closed angle glaucoma. That's it. But like glaucoma means increase in the pressure here. So when you have open angle, most likely it end up by cataract. When you have closed,
Help this to know which medication is more suitable for. Okay.
that's it.
Right now.
That's it. Don't try to understand more about it, because if you go deeper, it's getting difficult. It's getting difficult
Yeah,
if you
I
go deeper.
understand. Yeah, I got it. Yeah. Thank you.
Welcome. Okay. Yes, myasthenia gravis. Yes, this condition is very weird condition. So in this condition, you will see your patient cannot initiate movement, or he cannot initiate movement, but in a very weird way. He cannot control it. So first thing you're gonna think about it. So this patient has problem with his muscle, but they found it no. This patient has autoimmune condition related to the acetylcholine receptors inside his muscles. So they found the acetylcholine receptor inside his muscle, skeletal muscle, to have antibody over it to prevent acetylcholine to come over the skeletal muscle receptor. So it will lead to impaired skeletal muscle movement. So how we are going to deal with it? We are going to deal with acetylcholine over these receptors. So it's not related to the muscle itself, it's not related to the calcium, it's not related to anything. It's related to this one, because you will see when we go for more medication or more disease, you will see some condition is related to the muscle itself. Some condition is related to receptor itself. But here, this condition is not related to the muscle. It's autoimmune disorder related to the acetylcholine receptor over a skeletal muscle. Okay. Okay. So this is all the information I would like you to understand from this chapter. What's here? Yeah, this is okay. So that was everything for the chapter 2. Before we move to chapter 3, do you have any question about it? Okay, let's move to chapter 3. Chapter 3 is discussing about cardiovascular system, about the tension, hypertension, arrhythmia, angina, and heart failure. Some conditions are extremely important for you to understand everything. Some other condition like arrhythmia, just know the medication and move. So we have class 1, 2, 3, 4. The medication is 1, 2, 3, 4. That's it. So if you want to dig deep about it, it's not very recommended, because they are not clinically relevant for us as a dentist, and usually they don't ask about it. Honestly, NDEB, as like, they are not fair, they are like horrible organization, but like when it comes to the question, they ask question from the pharma which is clinically relevant to us. It's not like asking like very stupid question. Okay, so here I discuss about the cardiovascular, like it's like intro for it, and then we discussing this condition: high blood pressure, congestive heart failure, arrhythmia, and angina. So high blood pressure is related to the narrowing of the blood vessels. So we have patient with like, imbalance in his like lipid inside his regime, like an diet he's taking. So it will lead to accumulation, atherosclerosis, accumulation of some stuff inside his blood vessels. So it will lead to narrowing of the space for the blood to pass. So how come the heart will deal with this condition? He will pump the blood harder and stronger from the heart. So when this happens, it will be reflected in your body as increase in the blood pressure. So when we try to measure it, you will see the heart is pumping harder. So this condition is very dangerous because of more than one reason. The most important reason is they call it a silent killer, because like the body is trying to compete and overcome this narrowing of a blood vessel by like increasing the intensity of pumping. But over the long term, this will act like devastating over the heart, over the blood vessels, specifically the narrow blood vessels in the kidney, in the eye, in the ear. So this is why they call it a silent killer, because once you discover some side effect over the kidney, it's done. Like it's very hard for yourself, for your patient. Okay. This slide speak about the number of hypertension and how we are going to deal with the patient. This one I'm going to ignore it now because we are going to discuss it in depth in the medical management chapter. And then we have medication. For sure, medication is coming after the lifestyle therapy. One second. We're going to ask our patient to make a good diet and then do some exercises, and then we are going to deal with him over six mechanisms. First one is diuretics. So for hypertension, we have increased volume inside our body. So the first thing and the easiest thing to be done, to give him medication to get rid of water. And then we're going to work over the heart itself. So we're going to give beta blocker or sometimes alpha blocker to let the heart to relax over it. And the calcium channel blocker, why calcium? Because like inside the muscle, and this include the cardiac muscle, there is a mechanism related to cyclic A and B, but whatever you need to know calcium is really critical for the muscle to contract. So if we are going to block calcium, so we are going to block the contraction of the heart, and most importantly, we are going to block the contraction of the peripheral muscle inside the blood vessel. So we are going to, when we block this contraction of the peripheral vessels, so we give more space for heart to deal with it. And then we have like other mechanisms to deal with it with ACE inhibitor, which is working over angiotensin renin system. I'm going to discuss it now. And then sometimes this medication will lead to coughing, because when you act upon it, it will lead to more LOX, which is leukotriene coming from other side, leading to coughing. So for this patient, we give ARPs, which is working over the receptor at the end. And finally, and this was confusing for me, because like when you think about it, patient has high blood pressure because of narrowing of blood vessels. So we can give him direct vasodilator. That's it. We vasodilate the blood vessels. Everyone will be happy. They found it to be only good in dealing with patient in emergency. Why? Because when you do vasodilation for the blood vessel inside your body, so it will end up by headache, orthostatic hypertension, because you are manipulating every blood vessels inside your body. Okay? And then we discuss about diuretics. Diuretics are really important, and it's really painful in the AFK exam, because sometimes he will ask you 5 questions about the hypertension drug. 4 out of 5 is diuretics. Sometimes 4 out of 5 to be ACE inhibitor. This is really sad, but this is what's really happening in the exam. So I would like you to know each medication and where does it work, and which one is most potent one. Okay. Okay, this is really important. Please, guys, study it. Okay. And then we discuss about this one. So you see now it's application for whatever you studied before. So you have beta blocker, alpha blocker, and this is, we discussed it before. Okay, and we said propranolol can be used, but like it's contraindicated in patient with asthma and COPD. And this is alpha 1 blocker, which was the Zosyn 1, and we said it's a very strong one. Okay, so let's move to something new. Yes, calcium channel blocker. So this is the calcium channel blocker I told you about. So for blood vessel to contract, it need calcium. So if we are going to block the calcium from coming inside the cells, so we are going to do vasodilation and decrease in blood pressure. That's it. But there is two families of the calcium channel blocker: dihydrobromidine and non-dihydrobromidine. What's the difference? So we have two muscles. We have muscle in the heart, which is cardiac muscle, and we have muscle in the periphery. So if our medication has more affinity to the peripheral muscles, which is nifedipine, so this nifedipine, it has more affinity over the peripheral vessels, so it will act more as vasodilator, which is dihydrobromidine. Which is non-dihydrobromidine, it's acting both over the peripheral and central. So this one, diltiazem and farbamil, so this two medication, it will act more over the heart. So let's say it again. We have two type of receptors for calcium channel blocker. Some medication has more affinity for the peripheral one, so it will act over the vasodilation. And some medication has more affinity for the heart. Why I'm saying more affinity? Because you don't think it's black or white. Because I think this is the problem with most of us as a dentist and pharma. Because nothing in pharma is working as black and white. Everything in pharma is working in a gray zone. So nifedipine, it's not working over the heart. Make no sense. Nifedipine, it will be working over the heart, but it's more effective against the peripheral blood vessels. And the other medication is working over both. Why I'm saying speaking about all this? Because you will see question asking nifedipine is more effective or has more affinity over this one or that one. And nifedipine mode of action is to decrease afterload. This one, the diltiazem and farbamil, mode of action to reduce heart rate and contractility, which means it's negative inotropic, negative chronotropic. Inotropic is the force and chronotropic is the frequency, if I correct. Maybe I missed it, but like this is the way of, this is the mean of inotropic and chronotropic. So this is important for you to understand about the difference between both, okay? Okay. Yes. You see this, usually I put the information here from the drug-drug interaction because like again at the end when we give you this file only so you can grasp the information. Okay, so the difference between both. Okay. And then ACE inhibitor. So ACE inhibitor, it's act by PREL and by PREL. Before we discuss about ACE, we should discuss about angiotensin renin system. So I have a slide here for it. No? No? Yes, here we have. Yes, we have long slide. Okay. So what's this system? So in your body, you have a system to deal with a volume of fluid inside your body and contraction of your heart. This system goes through three major organs: liver, lung, kidney. Liver, lung, and kidney. So the circle starts by angiotensin. Liver in the normal situation is giving angiotensin to work over your body. And then the kidney is giving renin. Renin plus angiotensin, it will give angiotensin too. Why you need to understand this way, this step? Because this step is the step where we are going to increase and decrease. So when there is a decrease in renal perfusion, what this mean of decrease in renal perfusion? Mean there is less blood flow coming to the kidney. Less blood flow coming to the kidney. When this happen in two situations. And hypotension, so your body need to act over it to do contraction to increase the blood. But when also this happen, when you have high blood pressure, and this high blood pressure due to narrowing of the blood vessel will lead to less blood coming to the kidney. So the kidney is having wrong signals. There is hypotension inside your body, and kidney would like more blood to do its job. So the kidney will give more renin to come to angiotensin to become angiotensin 1, which will lead to contraction and increase in blood pressure. While your patient body is having already blood pressure. So this is the problem with this condition, with this mechanism. Because the mechanism here is giving wrong signal to the kidney, there is hypotension. And the kidney will give renin, which will induce more fluid to be accumulated in your body and asking the heart to pump more. So it will lead to more hypertension for your patient. So this is, we are going to act over this mechanism. So it starts by angiotensin from liver, renin from kidney to become angiotensin 1. and then angiotensin 1 will go to the lung to be acting over the ACE, which is like I forgot the name, but like this is the sort for enzyme which is going to convert angiotensin 1 to angiotensin 2. Angiotensin 2 will act everywhere. It will increase the thermostatic activity, which more pumping of the heart, narrowing of the blood peripheral blood vessels, act over the sodium chlorine inside the nephron to do more retention of the water, aldosterone secretion coming to again retention of the water, vasoconstriction of the peripheral blood vessels, and then act over pituitary gland to reabsorption of more fluid from your kidney. So it will lead to more water and salt retention, and this one will lead to more perfusion in the kidney. So the kidney will happy now. Kidney is happy now, but your body is not happy. So why am I saying all this? Because this is how we are going to act over it. And sometimes ask you a question, angiotensin 1 is converted into angiotensin 2, where? And you will see the answer in the lung, and it will drive you crazy. What the lung has to do with all this? Nothing. This is the mechanism. So the three major organ: liver to give angiotensin, renin to give kidney to give renin, lung to is the place where the angiotensin 1 will be converting to angiotensin 2. So ACE inhibitor simply is working over the ACE enzyme, like this. You remember the same mechanism of acetylcholine esterase. So we're going to inhibit this ACE. So we're going to inhibit the conversion of ACE1 angiotensin 1 to angiotensin 2. So we're going to break all the circuit. Nice. But they found the problem with Prel family. When you inhibit this one, there is other way of like in the mechanism of these enzymes, which is leukotriene. Leukotriene, which in short we're going to call it LOX. So when you inhibit the ACE inhibitor for angiotensin 1, it will lead to more LOX. This LOX is acting over your lung to lead to coughing. So sometimes this patient will end up by coughing. So we're going to switch the medication from angiotensin inhibitor, which is ACE inhibitor, to ARB. ARB acting over this one receptors. So we are going to let the ACE to work over angiotensin 1 to give angiotensin 2, and then we are going to wait for angiotensin 2 at its receptor to block it. So angiotensin 2 is not working. So most likely we are going to start by ACE. If it's end up by coughing or our patient start to be asthmatic or severe COPD, so we are going to end up by ARB. Okay. Okay, here angiotensin, which is ACE inhibitor, act by Prel, this medication, and then I discuss about it. And I would like you to understand the Prel is the main line of the standard line of treatment. You see here, this is the problem. When you block the ACE inhibitor from angiotensin 1 to angiotensin 2, it will lead to, it's not here, it will lead to more leukotriene coming on the other side. So patient end up by coughing, so we are going to work over the angiotensin 2 receptor. So we're going to lead the angiotensin to act, and then angiotensin 2 to be formed, and then we are going to block the receptors. This medication will...
Excuse me.
Yes.
Is the coughing from using ACE is from bradykinin?
Say it again, doctor.
The coughing from using ACE inhibitor, is it from bradykinin?
I think it was from
In the lung?
leukotrienes, or I remember it was...
Bradykinin.
Yeah, 1 second. Yes, yes. I remember it has something to do with leukotriene. Maybe it was the aspirin or NSAIDs. Maybe, yeah. I think you are correct. Yes. It's bradykinin.
Okay, thank you.
Yes, bradykinin, not leukotriene. Yes, leukotriene, which is LOX. Yes, it's the same action, but like it's acting over the COX-1, COX-2 as a different mechanism, but it will end up by coughing also. Yes.
Leukotriene for the steroid, right?
Leukotriene.
Yeah, for the steroid.
Yes, steroid, and also the NSAIDs. You remember NSAIDs when it's act over the COX-1, COX-2, it will lead to more leukotriene coming from the other side, which will act over the lung. This is why patients with severe asthma, COPD, we don't use NSAIDs for them. Correct. Yes.
Yeah.
Okay. And then angiotensin 2, we said Prel for ACE inhibitor. ARB, it will end up by sartan, losartan, valsartan, this medication. Again, one or two information about it. Here I'm explaining why I'm explaining about each medication in each slide, because at the end of the year you are going to read only this page. So when you read losartan, you are not going to read the whole chapter. When you read this one, you will see how does it work and the side effect about it and how you are going to avoid it. Okay. Finally, direct vasodilator, as we told you, as I said before, like it has action to be most likely used in emergency only, not all the time, but some medication to be used all the time. We have minoxidil and we have some other medication to be working. I would like you to understand one or two words about it, and that's it for this one. Okay, so if we have our patient with hypertension and he's not, like, we give him medication but he's not taking his medication, he's still having a bad diet, he's not exercising, so the heart will try its best to accommodate the problem. How the heart is going to accommodate the problem? So the heart has more than one mechanism to deal with it. So first, the heart will reduce myocardial workload or decrease extravascular fluid volume or improve cardiac contractility or reduced rate of cardiac remodeling. All these four mechanisms is amazing way of the heart to deal with it, but it will end up by more load coming over the heart, which will lead to what we call, you see, this is the correct heart and this is the not very good heart, because like the heart first will act by stretching of the muscle fiber to increase the volume. So the heart think when we increase the volume, we can pump to give more blood coming into the periphery to lead to perfusion for renin, not to come from the kidney, because kidney is shouting we need more blood. And this way will act over the heart to be hypertrophic. And the heart, when become hypertrophic, it will lead to less efficacy of the heart to pump blood, and this will end up by fluid accumulation from the coronary artery. All this you don't need to understand. I just would like you to have it in your mind. And then we are going to deal with this patient by angiotensin inhibitor, ACE inhibitor, or ARBs, all aldosterone antagonists, beta blocker, diuretics, direct vasodilator. So all this medication, we just discussed them. Finally, we have a new medication which is inotropic agent, which I'm going to discuss now. Okay. So you see, this is why I told you when you study the first two chapters effectively, the other chapters will become as like application for this one. Heart failure warning signs, we are going to discuss it in the medical management chapter. Okay, so medication ACE inhibitor, ARB, beta blocker or alpha blocker, diuretics, they're acting vasodilator, and we have here three new medication that I'm going to discuss now. Inotropic drug, beta adrenergic agonist, and phosphodiesterase inhibitor. So inotropic drug, which is digitalis, or the other name is digoxin. Digitalis or digoxin is a very potent drug because even in the low volume, it can act over your heart to increase the contractility. How it's increase the contractility? Do you remember the cyclic AMP I told you about? It's happening here inside the muscle and leading to calcium. So the digitalis is working over this sodium calcium dependent triphosphate with ATP enzyme and overworking the sodium calcium exchange channel to lead to more calcium inside the muscle. When you have more calcium inside the muscle, so when it receives the signal to act, to contract, it will contract faster and harder. So when it's contract faster and harder, will lead to more blood coming into the blood vessel. So in a way, you are going to overcome the narrowing of the blood vessel. Okay, but again, we said like this mechanism, it will like compensate for that, but like on the long term, it will ruin your heart itself. Okay. The problem with digitalis, it has very narrow therapeutic index, and this is why we use it only with severe congestive heart failure after ACE inhibitor and beta blocker and diuretics. So not all patients with congestive heart failure are going to give him digitalis. We're going to give digitalis when it's not working, the other medication. Why? It has very narrow therapeutic index, and it has ataxia, anorexia, nausea, vomiting maybe happen, and it might lead up to toxicity. So sometimes question asking you about toxicity signs. So the question will be like, your patient is taking digitalis. What the signs and symptoms you should warn your patient about when it's happened to come to you back. So this is the sign of toxicity, which is blurred vision, and this is the most commonly one. Yellowish vision. The patient will tell you, I see some yellow inside my eye, and arrhythmia. So when your patient has arrhythmia or this yellow vision, so this means he has toxicity. So again, nausea, vomiting, it's not normal, but it's a side effect which we can tolerate. But when your patient goes to arrhythmia, so this means he's in a toxicity side. Okay? Someone has a question?
I want to ask about digoxin.
Yes.
It's used in the late stage in congenital heart disease
Yes.
when we have hypertrophy,
Yes.
right?
Yes.
When the muscle becomes thin, so we need the contractility to be more efficient. We start using digoxin, right?
Yes, correct. We're not going to use it from the
So
beginning.
it's not gonna affect the volume of the blood. It's gonna pump. It's gonna induce the heart to pump more.
Yes, so when you induce the heart to pump more, it will lead to more blood in the blood
To move
vessels.
the fluid from the heart to circulate more.
Yes.
And what about the butamine?
The butamine acting.
What's different?
Yes, it's different mechanism. Let me go to butamine. So
We use it at the first stage.
got you. Yeah, got you now. Okay. So the butamine is a medication working over D1, D2. It's in the heart. It will act to increase inotropic, chronotropic. But this medication is emergency medication. So you don't see patient with a congestive heart failure. He has the butamine pills. No, the butamine is giving IV only in hospitals.
Yeah.
So the butamine
Which one is the late? The butamine is the at the late stage, or digoxin at the late stage?
Okay, so
I was wrong, maybe, right?
no. You are correct, but like it's a different time frame. So when your patient has congestive heart failure and he is in emergency, go to hospital. We are going to give him the butamine, okay, in the hospital, IV, okay.
Yeah, okay.
But once he goes home, we give him digitalis.
Yeah, I got it.
You understand this?
Yeah.
So the butamine is emergency to be taken IV in hospital, but digitalis is like for later stage when he goes home.
Okay, thank you.
You see here, this is the butamine. Yes, it's the next slide. Yes. Okay, the butamine is working over almost the same mechanism. It's almost over working over cyclic A and B inside it. It's had the same way of acting, but this medication is for emergency. It's used only IV in the hospitals only. Okay. Okay. And finally, we have milneuron. Milneuron is same acting here. So everything is working over the cyclic A and B and ATP. Cyclic A and B and ATP and increase of calcium inside the muscle to be contracting more. But again, this medication is only used in emergency and hospital. Finally, because I know it will be confusing after all this, we have order of therapy. So they divide it over the 4 stage. So first, we are going to start with hypertension and ACE inhibitor or ARB. So if patient is good and he's recovering, okay. So if patient is not recovering, so maybe we can add beta blocker over it. Is good, okay. If patient is not recovering, so we are going to add more medication. Finally, we end up by digoxin. You will not see here milneuron and butamine again because this is for emergency. When he goes to emergency condition to hospital, we give the medication. But here we discuss about the medication he will go and take home. Okay, doctor? Okay. Arrhythmia. I think I discussed this one in depth. We're not going to do it again, but like I would like you to understand the heart has its own pacemaker because the heart is a muscle which is like self-contracting, so it's not related. It will not wait for the signal to come by a style clean to work over it. It has different way of acting, but this way of acting it will lead to it's a very complex. If you remember from what we discussed in the video, it's very complex way of acting. So it might end up by arrhythmia. Arrhythmia most likely coming from sometimes because of patient congestive heart failure, it will lead to hypertrophy of the muscle. So sometimes the muscle will be dead in some parts. So let's think about electric circuit when there is dead part in this circuit. So the electricity will go and then in this part it will zen and then come back or backfire in different way. So when this happen, it will reflect it over your body or over your patient with this EKG to be like, it's not like you see this is a normal heart. We have B wave, QRS and T wave. This way, no. Or sometimes there is like problem with the heart itself not to give the firing action incorrect. Okay, you don't need to know more about it. And this is the cause of arrhythmia and we discuss here about it. This is a slide I would like you to remember and know. Other stuff.
Excuse me, doctor.
Yes.
Like for anti-arrhythmic drug, I saw some questions about supraventricular tachycardia and all this stuff. We should know all this stuffs in depth,
No, no, no,
or
no, 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 no.
no, we don't have.
You see this slide? This is a
Only
slide.
only the groups, right? We should
Correct.
differentiate.
Yes, that's it. You see class 1, class 2, class 3, class 4. This is you should know because the question will come to you. This one is class 1, this one is class 2. He will not ask you question about this one to be treated supraventricular no. Don't you don't need to know this stuff. Okay?
Okay.
This is the information I would like you to remember. Okay? Okay. Again, I give you more like this is for your like information. I don't want you to memorize all this. This is the information I would like you to memorize. More than this is too much for us as a dentist. Okay. Finally, we have angina. Angina pectoris is happening due to again atherosclerosis. The heart itself has its like a specific network of blood vessels which is nourishing the heart. So it has no exception not to be blocked by atherosclerosis. So when our patient has high blood pressure, so it will also be blocked. 1 second. Okay, doctor, no problem, no problem. Thank you, doctor. So the lecture. 1 second, let me confirm it's recorded before I say yes. It's still recording. So the lecture is recorded. I will post it on the website. Okay, thank you, doctor. Thank you for confirming. So when we have narrowing of the blood vessels, so it will lead to less blood fluid coming into the heart to be to be nourished. So the heart need blood, so it will release this adenosine and the bradykinin. This two type of signal, it will give you this severe pain because this is really important. If your heart is not receiving sufficient blood, so this is very dangerous for yourself. So this is why you have this mechanism to have this pain. Okay. How they come to know this one is related to this because they found it to be an increased level when your patient has myocardial infarction. So they come to conclude this two protein or two signals is coming from this way. Okay. So you need to know about the types. We have stable and unstable. What's the difference between stable and unstable? It's one simple difference. When you give nitroglycerin and ask your patient to relax and the pain is gone, it's a stable one. When it's happening at rest and patient is taking nitroglycerin and patient is resting after having it and it's not relieved, so this is unstable. That's it. There is nothing called myocardial infarction. Please, guys, myocardial infarction is emergency. Myocardial infarction is emergency. It's not a condition. Myocardial infarction means unstable angina attack. So your patient has attack. So when you have this attack, we call it myocardial infarction. So myocardial infarction in like layman language or simple term, the patient he is going to call it heart attack. So every patient has heart attack, so we are going to deal with him. But there is critical information for your knowledge here and for medical management. If the question is speaking about chest pain in like radiating to the left side, and you see in the question there is no mention of hypertension or history of angina, we are going to consider it as MI. Why? Because we want to be safe. We don't want to gamble with the patient life. But if your patient has history of angina and the question telling you patient feeling chest pain and pain in his left arm, so are going to deal with it as a stable angina. What's the difference? Difference in stable angina, nitroglycerin, and wait for 3 times. Unstable angina or myocardial infarction, you are going to give epinephrine and then you are going to call 911. Okay. Finally, we have this variant angina or
Epinephrine, we give epinephrine.
sorry,
Nitroglycerin.
nitroglycerin again. Yes, but like and the second one in myocardial infarction, are going to call 911 immediately.
In cardiac arrest, we give epinephrine.
Yes, cardiac. When he goes to be cardiac arrest, yes, after myocardial infarction, if you cannot manage him, he will end up by cardiac arrest. Correct. Yes. Finally, we have what we call variant angina or atypical angina or presenceptal angina. You will see a different name for it. So this one is not related to atherosclerosis. This one is related to transient vasoconstriction happen in the blood vessel. So when you have transient vasoconstriction happening in the blood vessel, so the blood coming on the other side will be less. so less perfusion coming to your heart, will give you the signs and symptoms of angina or angina attack. But it's not related to the atherosclerosis. Why this is important for you to know? Because I would like you to understand the way of mechanism of this one. It's related to this one. Why this happened and when this happened, they don't know. But they found some
They
patient.
don't know why the spasm happened.
No, they don't know. Why this is important for you? Because like the way of dealing with this one is not related to atherosclerosis. So this patient might have some stress, so much stress. He maybe like have like they found it to be related to stress and cold environment. It's not related to the atherosclerosis or hypertension. So doctor, this happened like most commonly on almost always. All patient with angina attack, he will have high blood pressure. So when it happened for patient without high blood pressure, so most likely it's coming from this mechanism. Okay? Okay. Again, the medication here, we have beta blocker, calcium channel blocker, organic nitrates, and sodium channel blocker. Okay, when we go to medical management chapter, we're gonna discuss more and more about this medication. And here the way of dealing with the patient. So most likely patient with no other medication, like you see here, patient with asthma, we cannot use the beta blocker here. Because like you remember we discussed about the non-selective beta blocker, we cannot use it here. We can use beta blocker to be selective one to avoid the interaction with the lung. Okay, I think we have two slides. No, this is the recap one. Yeah, this is the recap one. Okay, so that was the third chapter, and then we have one more chapter which is not that heavy. Before I move on, do you have any question about the previous stuff? Okay, I hope the lecture is not very boring because I don't see interaction. Okay. I aim for this lecture just to give you the critical information because I received the feedback. All this information we need to know. Yes, you need to know, but like not in the same way. Like you say, I give you slides for arrhythmia, but I told you only the medication. But like when we go for diuretics, no, you need to understand everything. So I hope this slide is this lecture is acting like a code for you to, when you restudy again, you know which part you need to focus more and which part you need just to move around it.
What do you mean by basic and critical? Both of them can explain. Like it's critical, it's very important, but basic.
Basic mean like it's speaking about the mechanism of action of basic drug. Like you are going to discuss about how aspirin work, how ibuprofen work, this stuff. So this is basic. Unlike when we discuss about CNS. So CNS, I'm going to tell you this for Alzheimer, we're giving this medication. This is related to this one. So if you don't know how the medication is working from CNS, so this medication will be difficult for you to grasp. So when we go to CNS, it will be advanced, you know?
So all we have to know only about the COX, how, and that's it.
Yes. So the first tag, doctor, is telling you the information is this chapter is like the level of knowledge. So this level of knowledge is like ground zero. So we're going to discuss about COX and how does it work. So but when we go to drug-drug interaction and drug-drug interaction, in the chapter you will not see the mechanism of action of ibuprofen. You will see the interaction between ibuprofen and other medication. You know what I mean? Okay, is this
confusing because basic and critical at the same time?
Yeah. Yes, yes. I know. This is why I'm explaining it. Yes, okay. No problem. Basic and critical. Yes, makes sense. Okay. So, analgesics. So, we have more than one family to be analgesics to relieve pain. We have antidepressant can be used, anticonvulsant can be used, corticosteroids and LA can be used. Moreover, we have opioids and non-opioids. Opioids, which is opioid medication. Non-opioids, we have NSAIDs and acetaminophen. So when you see this slide, can you see barb or benz? No, you don't see barbiturates. You don't see benzodiazepine, correct? So you will see this famous question about the benz or barb to have analgesics effect. No, basic benz or barb is not to be used analgesics, and it has minimal like effect as analgesics and not to be used as analgesics. So you're gonna ask me, how come antidepressant to be used as analgesics? So I'm explaining. Sometimes patient has chronic pain. What's the meaning of chronic pain? He has like problem with his most likely it's
Carbamazepine.
coming. Sorry.
Talking about nerve, trigeminal nerve, right?
Yes, correct.
Carbamazepine.
Yes, correct.
Okay.
So for this patient, he is in severe pain. We cannot give him opioids forever. So we are going to give him other medication to deal with this pain. Or some patient has back pain, chronic back pain, or some patient has problem with the neck itself and muscles in this area. So we cannot give opioids forever because he will be addict. So we are going to use this medication as analgesics. Why I'm explaining this? Because like when you see this slide, you feel like I'm going to give gabapentin and analgesics. Yes, you're going to give it as analgesics when your patient has trigeminal neuralgia, he has severe pain, and you cannot give him opioids forever. So this can be used, but the bottom line here, we cannot use barb and bens as analgesics. Okay?
Excuse me, gabapentin, we can use it for trigeminal, right? Carbamazepine only.
Gabapentin.
Because, yeah,
Say it again.
gabapentin is
Say it
for the
again.
back. Carbamazepine, we can use it for trigeminal neuralgia.
Yes.
But gabapentin, it's only for back pain.
So
Can be used.
in trigeminal neuralgia, I remember I read in textbook it was like
Carbamazepine.
carbamazepine or gabapentin or pregabalin. It's like acting like
My friend told me, like in FK, he had this question. Was mentioned gabapentin and the carbamazepine. When he used, he checked the gabapentin, it was wrong answer for him.
okay. So again, it's acting like in cascade. So first to be carbamazepine. If your patient has some contraindication of carbamazepine, it will be gabapentin. If he cannot use gabapentin, it will be pregabalin. So you understand? You got me now. So this is tricky question because like options are correct, but like what is the first indication to be used to be carbamazepine? So again, like when you see some, he will give you rivastigmine, neostigmine, physostigmine. So all three medication can be used for Alzheimer, but you are going to use rivastigmine. Why? Because rivastigmine is easy to be applied. It's transdermal patch. It has less side effect. But all three medication is working at the same level. You remember this question about like which medication can be used at anti-motion sickness? Scopolamine is the answer, but the other medication can be used, theoretically can be used, but clinically they found this one to be more effective. So it's a tricky question. Yeah, I know. Gabapentin can be used. When you see in the question, some question you will not see carbamazepine. So which one you are going to pick?
Gabapentin.
Yes, this is correct. Yes, so this is correct. Amazing. So it's not like correctly entirely wrong, but this type of question, sadly, it's like it's coming in the exam, and you will see it like sometimes you will see a question which of the following has severe drug-drug interaction with ibuprofen, and he giving you 4 diuretics. It's all diuretics, giving you 4 diuretics. So which one it is? It will be the most potent one, and you will see the slide in drug-drug interaction. It's giving you the slide and giving you ibuprofen, mention all the different type of diuretics, saying it has interaction, and when it goes to this specific medication, he will tell you this is the most potent drug-drug interaction. Okay, so for analgesics usually we are going to use non-opioids or opioids, okay? And then this 4 other medication families, we're going to discuss it when we go to CNS. So how it's working, the analgesics effect. So analgesics effect working over a very simple mechanism. So analgesics is related to relieve pain and acting as anti-inflammatory, and sometimes is acting as antibiotic to deal with the hyperthermia inside your body. So how does it work? It's working over this mechanism, COX-1 and COX-2. So COX-1 and COX-2 is enzymes giving prostaglandin. Prostaglandin will have some good effect and some bad effect. But to be super frank and to be scientific, the pain itself is not a bad effect. Why? Because when your body is going through inflammation and giving you pain signal, so the body is like sending help me signal. So it's not a bad sign by itself. But no one would like to go through pain. When you have inflammation, we would like to get rid of inflammation. So this medication is working over both mechanisms. It will relieve the pain and lessen the inflammation, and sometimes dealing with the pyretic action over centrally. But I would like to understand COX-1, COX-2 for NSAIDs is working peripherally, meaning it will be working over the site of action. it will lead to analgesics and anti-inflammatory action. But the problem when we are going to block prostaglandins, there is some prostaglandin which is more beneficial for us, like prostaglandin E2, which is protect the stomach working over the kidney function and working to induce fever and pain. So when you stop prostaglandin E2, you are going to block the pain, which is amazing. But at the same time, you are going to expose your stomach for the acid inside it. So maybe it will end up a peptic ulcer, or you're working over the kidney. So if you're having diuretics to be working as antihypertensive medication, so it will ending up by rendering this medication to be ineffective. So this is the problem. And the same with the prostaglandin I2 is working over vasodilation and platelet aggregation. So if you're giving NSAIDs for very long time, so platelet aggregation is not working. So this is a side effect of dealing with NSAIDs for very long time. NSAIDs acting selectively from COX-1 to COX-2. So COX-1 select, yeah, why? Yeah, this is really nice. So they found most likely, the protective prostaglandin is coming from the COX-1 family. So they think about it. Okay, so let's us try to make a medication which is only over COX-2. So when we leave COX-1 and working selectively over COX-2, so we are going to leave prostaglandin E2 to be working over the kidney and the stomach, and everything is happy. They did it, and once they try it, which is silcopsib, they found it. They ended up by increasing the risk of cardiovascular accident, increasing the risk of your patient to have a stroke, increase the risk of your patient to have a myocardial infarction. So they ended up by this medication not to be effective, and they throw it in the garbage. So at the end of the day, you are going to use this type of medication, which is aspirin and ibuprofen and naproxen, to be used as analgesics from this family. The information I would
What
like.
about acetaminophen? It's the central, which works on COX-3.
Yes, or box, COX-3 or
Okay.
box. Yes, yes, yeah, yo,
Okay.
nice. This is very good catch from you, doctor. So the main difference.
Last question. You've asked about what type of antidote that like act for the acetaminophen. Yeah.
Which one? Tell me.
Like I've searched for it. Like maybe it's cysteine, but
Yes, yes. It's called ansencysteine, stuff like this. Yes.
yeah.
Yes, and it's very dangerous. Like this condition is dangerous, and most likely, sadly, is irreversible. Means when your patient is taking a lot of acetaminophen, the part in your in your liver to deal with acetaminophen later is broken forever. So this patient cannot take acetaminophen again. And sadly, they found this is the most common type of toxicity happen in some countries. Patient is taking too much acetaminophen. Okay, so Dr. Muhammad was, yes, the difference between ibuprofen and acetaminophen, and this is why we don't consider acetaminophen to be NSAIDs. It's acting centrally. Acetaminophen acting over the COX-3 or box centrally, not peripherally, and this is why acetaminophen has very limited anti-inflammatory effect. Very limited anti-inflammatory effect. Okay. So from this, what you need to know about aspirin, ibuprofen, and let me give you a
You were talking about the antidote for what? Sorry, I missed it.
antidote for
Can
acetaminophen.
you repeat? Antidote. What's the antidote for that?
It's called N-acetylcysteine or like something like N.
Acetylcysteine.
Yes, I will post it on the website a slide for it because I would like you to be more alert. Thank you, Dr. Ahmad, for catching this and answering this because I would like you to be interactive. Yes. Okay, from this, I will give you a golden rule. Golden rule is saying this: aspirin during your journey with NDEB. When you see aspirin, aspirin is not used as analgesics anymore. Aspirin is not used as analgesics anymore. When you see aspirin, most likely it will be related to antiplatelet effect. It's not related to analgesics. Why? Because it has very significant and severe side effect over wide range of people, specifically kids. When you use aspirin for kids as analgesics, it will lead to yes, amazing, and this is fatal one. When you search about it, it's a fatal condition. Most likely, it will damage liver and brain.
The brain.
Yes, and it will be fatal. Most likely, the kid will be gone. So, child has herpes, and you give him aspirin to kill him. So this is why we don't use it. Aspirin to be used as antiplatelet. And why? Let me tell you why. And this was like really interesting. So you think about, we use aspirin as antiplatelet. Why we don't use other members in the NSAIDs family as antiplatelet? Why?
Because aspirin is irreversible, the other are reversible.
Nice, amazing, amazing. I'm so happy. So I think you are watching and you are enjoying. Yes, correct. Yes, because aspirin is irreversible acetylization of the platelet, so it has till the action of platelet to be gone, which is 7 to 10 days. But the other family,
And it should be taken in lower dose, because if it's
81.
taken in higher,
Yes.
it's gonna do the first effect.
Yes, from 81 till 325, it will act over COX-1. From 325 to 1000, it will act over COX-1 and COX-2, and it will lose the action of working over the platelet action. So we are going to use 81. In Canada, they make it 81.5. Anyway, so this is all for NSAIDs. So I would like you, for NSAIDs, I would like you to know this information also, because sometimes asking you, aspirin is from which family? As this, like you said, this one. The most commonly one is propionic acid derivatives, which is ibuprofen. Sometimes asking you this information. And then we discuss about aspirin now and mechanism of action. We don't need to say it again. Okay, it's acting irreversibly. And here the problem with this one. Okay, so let's move to here. Yes, ibuprofen. Ibuprofen is the same NSAIDs and non-steroidal anti-inflammatory drug. It's acting over COX-1, COX-2 peripherally. It's anti-inflammatory, antipyretic. Antipyretic is working here, and the main signal in the CNS, not related to the peripheral action. And again, this slide is like, it's good for you to know. Like, what you see here, one information about each medication. I would like you to know only one information about the medication. That's it. Okay, patent ductal arteriosus. Okay, so let me explain this. It's related to the medical management, but this is, it was asked at the last cycle. So what this mean? So for fetus inside the, during pregnancy inside his mom, he is not breathing air, correct? So he does not have this pulmonary circulation. So there is connection inside his heart to mix between oxygenated and non-oxygenated blood, because he's not breathing. So the blood is coming this way. So this duct should be closed before he come to be born, which happens in the last trimester during pregnancy. So if the pregnant woman is using ibuprofen in the last trimester, it will lead to failure of closure. So when this fail to close, this ductal arteriosus, when it become patent, mean it's like still open. So this kid, when he's trying to breathe, the blood with oxygen will be mixed with the blood with no oxygen. So this is extremely dangerous, might lead for this kid to be dead. So this is very, very important for a woman in the last trimester to avoid ibuprofen. And ibuprofen is a type of medication which has two categories for safety during pregnancy. So in the first and second trimester, it can be considered as B. But when we go to third trimester, it's considered as D. We cannot use it and in the last trimester as analgesic. So how about a woman which is pregnant in the third trimester and she has severe pain? We are going to give her pure opioid for a very short time. We are not going to give ibuprofen. But here we have a different.
Start with acetaminophen, right?
So it's
If
yes,
moderate.
yes,
If it's not working, we can add oxycodone or.
amazing, correct. So the algorithm of dealing with a patient, Dr. Muhammad did watch the lecture from before. So the algorithm is dealing with two factors. First factor, the level of pain. So if pain is mild to moderate, acetaminophen. That's it. If the pain is severe, we're going to start with ibuprofen unless we have contraindication. What's the contraindication for ibuprofen? Pregnant woman at the third trimester is one of those. Uncontrolled hypertension, congestive heart failure. It's other condition to contradict with ibuprofen. But for this purpose, for this patent ductal arteriosus, for patient and third trimester with severe pain, we're going to start with combination. In severe pain, we're going to start with T3. But sometimes T3 is not working, which is acetaminophen and some opioids. So in this way, we are going to give her pure opioids for a very short time. Okay, and you will see a huge debate about this following information. Codeine cannot be metabolized by kids. So how come we give codeine for a woman which is pregnant, and this one can go through the placenta to go to the kid and might lead to depression and like eventually making the kid to be dead, which is good information, but like in clinical relevant, they use T3 for the pregnant woman. If you want to use pure opioids, you can't use codeine. You are going to use different family. Anyway, let's not dig deep about it. When you go to medical management, we're going to explain it in depth. But like this is the information I would like you to know because this question was asked in the last cycle. And then we have celecoxib, which is selective COX-2, and we said we are not going to use it anymore because it's increased the risk of the cardiovascular accident. Finally, we have opioids. So opioids is working centrally and is not working over the COX-3 or box. It's working over MAO, GABA, kappa, and delta. So these three receptors is where the opioids work. So opioids is a huge chapter. Okay, so what information I need you to know? Let's be super selective. So the information I would like you to know, the classification of opioids. So we have two classification, to be agonist, antagonist, or weak agonist, or strong agonist. So this information I would like you to know. Second information is the when it comes to classification about is natural, semi-synthetic, or synthetic. And this is important information. Why? Because if we have allergy for morphine, so this patient is allergic to all the semi-synthetic and can use the synthetic, which is fentanyl, ibuprofen, or tramadol. So this is the second information. Third information, for each opioids, I will give you some medication name. I would like you to know when we are going to use it and one side effect of it. And that's it. Because if you want to study opioids in depth, you will spend long time. So this is the information I would like you to know from the opioids family. Okay? How the opioids work is working centrally over this action potential. So it will lead to what we call hyperpolarization, which means the signal is coming, patient is feeling pain, and the nerve is firing, but the brain cannot read this signals, so it's not working for him. Okay? And this is why it's dangerous. Why it's dangerous? Because like I told you before, pain is a beneficial in a way because it's a signal. Your body is sending you a signal. Please pay attention. I need you to relieve the pain, to deal with the inflammation. When the patient is taking this medication, the level of tolerance happens. You give him this medication is working. And then the body is trying to overcome this one. So there is tolerance happen for this opioid. So we'll increase the dose till he become an addict. So this is why we don't use this medication for a very long time. Okay? Opioids, the problem with opioids, it will lead to respiratory depression. This is respiratory depression is fatal. If your patient is taking alcohol with this one, it will be fatal. Why it will lead to respiratory depression? Because they found opioids to be working over the center in your brain to make it less sensitive for carbon dioxide. So how they call it hypercapnic drive. So in normal patient, not in COPD or asthmatic patient, the major factor to control breathing is the level of carbon dioxide in your body. When the level is less, the central nervous system is feeling this one. Opioids making this center to be less sensitive for carbon dioxide. When it's less sensitive, there is less carbon dioxide, but your patient cannot breathe, so it will lead to death. Okay? Okay, and then we go to about the information. Please, 1, 2 information about each and move. Because if you want to study opioids in depth, it will be a nightmare. Trust me, it will be a nightmare. Don't waste your time studying opioids in depth. I just would like to confirm this information. So naloxone is antidote. It's used to reverse the coma and respiratory depression opioid overdose. And there was a very weird question coming like few cycles ago. So what's usually is the side effect of rapid injection of naloxone when patient is having opioid overdose? Even the question when you read it, it's very difficult to grasp. So they found within 30 seconds of injection, respiratory depression and coma has been reversed. But anyway, this naloxone is used only for emergency. When the patient goes home, we need to give him other medication to deal with it. Okay? Okay. So this is the information I would like you to know. And finally, we have this slide. It has mostly all the information you need to know. Fentanyl is 100 times more potent than morphine. They love to ask this question a lot. Codeine is the weakest one about codeine and morphine and cross allergy between both. Okay. Again, for opioids, I intended now not to explain more because opioids, if you want to study it, it will drag you to the maximum. I would like you to know the classification. So when I tell you any opioids, tell me classification: synthetic, semi-synthetic, or natural, and tell me it's agonist, antagonist, or weak agonist, antagonist, and one indication for using of this opioids and one contraindication. That's it. Please do not dig deep in this information. It will drag you to a rabbit hole. Okay? Okay, so that was everything for chapter 4. Before we move, now we are going to discuss the quiz, the 10 question and the quiz, and answer of the 10 question. Before we move on, do you have any question for this one or the previous 3 chapters? Okay, so I will consider this as no. Okay. One last question before we move. Do you think the rate of the lecture was fast, slow, is good? What do you think about it? I would like to get a feedback about it.
No, I guess it's good. Like you're concentrating on what we should like know better. So I guess yeah, it's useful. Yeah. I like
Okay,
it.
okay, Dr. Lina, thank you, thank you.
I want to ask a beautiful question about how to memorize all of those, like the names of the drugs. I have a problem. Like every type of, not all of them, like most of the questions that have inside the quiz, I got wrong answers because I couldn't memorize all of those drug names. This is the main issue.
Okay, okay, so let me give you advice. First of all, it will take time. Just let's like get your expectation low. It will get time. It's not like you will memorize everything like this, like medication for opioids, like you will memorize everything in one time. No, you should understand this because it will relieve you. Don't stress yourself about it. So my recommendation is this: to take it one step at a time. Meaning, you remember when you say Odol is like beta blocker, A to N, Pril is ACE inhibitor, this docent to be alpha 1 and this one. You remember this mnemonics is very important. This one will save you a lot of time. So this is the first thing you should aim for. Secondly, what I did use, and it's, trust me guys, it's very beneficial. Before you go to sleep, I will share with you this study set. You just pick 10. This study set has maybe 230 drug. 230 is too much. Trust me, just take it 10 by 10. Each day you take 10. You read this 10 medication, you memorize it. So rivastigmine is this one, used for this one. Neostigmine is like rivastigmine. It's used for only, this is, I think, used for just the diagnosis for this one. I cannot remember it now. But like you will see this card, it has very limited information about each drug. You study 10, you sleep. Second day, you study 10, you sleep. After 5 days, you are not going to study anything. You are going to repeat all 50. Sixth day, you are going to do the same. So maybe 1 month, 2 month maximum, you will see yourself retaining the information. So you, again, you might think why you don't just give us this information and then we save our time not to study everything. Again, if you get the information without having the back knowledge, it will be nothing. You will memorize it and then it will be gone very soon. So this way, I trust me, I use it myself, and up till now I remember some medication. I was like, why I remember this one? Because you do it before you sleep. 10, 10, 10, 10. After 2 months, you will be in a good shape. Okay, doctor?
Quizlet is a good application for that too.
Yeah, I will share it with you on the website. I will give you the link and you will see it. And maybe I will make a short video about it, how to study it. And I love Quizlet. I can share it as PDF. No problem with me. I can share it as PDF. But I like Quizlet because it will quiz you. What's the meaning of quiz? He will give you the medication and then you will tap it. It will give you the names. So sometimes you can make a quiz about it. You can make it's up to you. It's a game. Like think it about as a game. Before you go to sleep, think cards. You make a quiz for yourself and then move to next think card. It's nice. I use it. It's nice. I will share it again with you as a PDF file. PDF file is coming. The medication, the indication, medication, indication, medication. Like it's, I don't like it honestly, but like I will share it also with you. Okay. And the most important part, do not stress yourself about it. It will take time. Okay, doctor? It will take time. Don't stress yourself about it. Okay? Okay. So any more question or any more stuff you need to clarify? nice. Let's go to the quiz. Here it is. Okay, let me change the sharing. Can you see the other application now?
Yes.
You see it now? Okay, nice. Where is my mouse? Yeah. Oh, 1 second. Okay, so let's start. I did it as 15 question and then I thought like this is too much for you guys, so I make it only 10 questions, okay? Okay. Which of the following change could oh, okay, 1 second. Let me because I cannot see from this one. Which of the following medication which of the following change could theoretically happen in a person when the parasympathetic system is inhibited using pharmacological agent? Reduction in heart rate, constriction of a pupil with meiosis, increase in gastric motility, dry mouth. So this question is very simple question asking you about the mechanism of action of the parasympathetic. So he's telling you now we are going to inhibit, which is like antagonist. So we're going to do as antagonist for the parasympathetic. So what do you think is going to happen? So from your knowledge, activation of parasympathetic system causes reduction in heart rate, constriction of the pupil, increase in gastric motility and salivation, and contraction of the bladder muscle, which is rest and digest. Inhibition of the parasympathetic system cause increase in heart rate, dilation of the pupil, decrease in gastric motility and dry mouth, and relaxation of destrusor muscles. So in this way, from this option, so the correct option will be dry mouth because we here acting as antagonist for the parasympathetic system. In the exam, please, if you are going to do it as a paper based, because you see inhibited using pharmacological agent, I beg you, before you read the option, understand the question. Because the feedback I received from people, sadly, they didn't pass the exam. They see a long question and they freak out, they go to option. Do not do this. This is why when I'm giving you the question, I give the question, read the question, and give the answer. Try to make it the same way. Make it a habit. Before you read the option, you should understand the question. Get the keyword and move. In the paper paste, you have your pencil. You are going to mark the major keywords of the questions. In the parametric and the like computer-based exam, you don't have this luxury, but you have pen and paper, you can write it. Please do it this way. Which of the following statement concerning the parasympathetic nervous system is correct? The parasympathetic nervous used norepinephrine as a neurotransmitter. No, we said it's acetylcholine exclusively, pre and post-synaptic. Parasympathetic system often discharge as a signal functional unit. No, this is not related to this. This is related to sympathetic because it's fight or flight. The parasympathetic division is involved in accommodation of near vision, movement of food and urination. Let's see. The postganglionic fiber of parasympathetic division are long compared to those of the sympathetic nervous system. So let's read it together. Okay. Where it is? Yes, here. The parasympathetic nervous system maintains essential body functions such as vision, movement of food, and urination. It uses acetylcholine, not norepinephrine, exclusively. So sympathetic, it's used acetylcholine, preganglionic, norepinephrine, postganglionic. And there is one more information about epinephrine, norepinephrine. So what's the difference between both? Epinephrine is working over alpha 1, alpha 2, beta 1, beta 2. Norepinephrine working over alpha 1, alpha 2, beta 1. Moreover, norepinephrine is secreted inside the synapse itself. It's secreted from the preganglionic. So the vesicles itself is creating norepinephrine. Unlike epinephrine, epinephrine is coming from the adrenal gland. Okay, so this is major difference between both. Okay, so acetylcholine.
Adrenal gland, it's stimulated by acetylcholine too, as well, right?
Adrenal gland.
Yeah, it's activated by acetylcholine, which secrete epinephrine.
Yes, correct. But like epinephrine is coming from the gland itself, you know.
Adrenal gland. Yeah. I'm adding the information.
Yes, yeah, but like I would like you to differentiate between norepinephrine is not coming from the gland. Norepinephrine is secreted inside the nerve itself. Okay? Okay. District fiber are activated separately, so meaning like in the parasympathetic system we don't need to fire everything in a one time, because again it's rest and digest, unlike the sympathetic it's be working as a one system. Postganglionic of parasympathetic system are short compared to those of sympathetic system. Adrenal medulla is under control of the sympathetic system, and this conclude the answer here to be the third option, I believe. Yes, the parasympathetic division is involved in a combination of near vision, movement of food, and urination. Norepinephrine, no. Discharge a single unit, no. And the postganglionic is shorter compared to the sympathetic one. So you see, it's all application of the information you just studied. Okay. Elderly man was brought to emergency room after he ingested a large quantity of carvedilol tablet. So you stop here. Carvedilol tablet. So what this medication is working over? So there is antagonist. We said it's non-selective. Alpha 1, beta 1, beta 2. A drug that block alpha 1, beta 1, beta 2 adrenergic receptor, which mainly mediate the cardiovascular effect of epinephrine and norepinephrine in the body. Okay, which of the following symptoms would you expect to see in the patient? So I'm telling you, I give this patient medication to block alpha 1, beta 2. So you will see increased heart rate. I don't think so, because like you block beta 1. Reduced heart rate, maybe, let's see. Dilution of the pupil, let's see. Increase of blood pressure. So by basic knowledge, you gonna know it's A and D is not correct, yes? Because you know, we blocked alpha 1, so increased blood pressure, no. Increased heart rate, no, because we block beta 1 also. So let's see. So activation of alpha 1 receptor cause mydriasis, vasoconstriction, and increase in blood pressure. So we block this one, so we are not going to have this effect. Activation of beta 1 receptor increase the heart rate, contractility of the heart, and blood pressure. Activation of beta 2 cause dilation of bronchioles in the lung, relaxation of the skeletal muscle vessel. Thus, inhibition of these receptors will cause vasodilation because we block alpha 1, reduction of heart rate because we block beta 1, reduction in contractility of heart because we block beta 1. Okay? So also reduction in the blood pressure and bronchoconstriction. Why? Because beta 2 is making bronchodilation. So when you block beta 2, you do bronchoconstriction. And this is why, if you remember, we said we don't use propranolol for patients with asthma or severe COPD. Because of this one, when we block beta 2, it will lead to bronchoconstriction. Okay? So out of these four, it will lead to reduced heart rate, bradycardia. Head and neck irradiation in cancer patients can decrease salivary secretion and cause dry mouth. All of the following drug or classes of drug are theoretically useful in improving secretion of saliva in this patient, except, so we're looking for the exception. So you make a big circle about it, or you write it down in the prometric and you read the option. Muscarinic antagonist, muscarinic agonist, acetylcholine esterase agent, or pilocarpine. So let's see. Activation of muscarinic receptor in salivary gland causes secretion of saliva. So we want to activate muscarinic to give more saliva. This can be achieved in theory by using muscarinic agonists such as pilocarpine or anticholinesterase agent such as neostigmine. So again, we have two systems to work over. So we know muscarinic receptor cause secretion of saliva. So either we are going to mimic the muscarinic receptor, or we are going to do antagonist of the other receptors. So I would like you to understand this concept here. So we have a receptor, we are going to work as agonists for it, which is pilocarpine, or the same concept to antagonist of the other system. So it will lead to overcoming or not overestimation. It will lead to this system not to be compensated with the other system, which in theory will lead to more saliva inside your body. Okay, so we can use anticholinergic agents such as neostigmine to increase level of acetylcholine. Muscarinic antagonist, which is anticholinergic drug, will reduce salivary secretion and worsen the dry mouth. Okay, so I would like you from this question to understand we might act by mimicking one system or anti-mimicking or antagonist of the other system, which will lead to this system to have more control to give the effect we want to know. We want to do. Are you following, doctors?
Yes.
Okay. Which of the following drugs would be the most effective anti-motion sickness during drug for a person planning to go on a cruise? Atropine, trobrocamide, scopolamine, and darfensin. So you see, all medication most likely will have the same action, but which one we're going to use? Yes, because like this is a clinical question. So all muscarinic antagonists, which is anticholinergic drug, are theoretically useful as anti-motion thickness drug. However, they found that scopolamine is the most effective in preventing motion thickness in practice. Okay? So other medication can
For gag reflex too.
say it again, doctor.
For gag reflex.
Yes, correct.
Patient was a gag reflex we used.
You're asking, or I'm confused.
No, I'm adding, right?
Yes, yes,
True.
yes, correct. Yes, yes. But again,
Both action we use it for scopolamine.
yes.
In dentistry and
Yeah, but like if you have the same question, but the question asking you, patient with hypersalivation, and you would like to control his hypersalivation.
atropine.
Yes, amazing, amazing. Scopolamine here is correct theoretically, but from the clinical point of view, we're going to use atropine. Correct. Yes.
Yeah.
Amazing. Which of the following is correct regarding adrenergic neurotransmission? Excuse me.
Why we choose atropine?
They found this is to be clinically relevant. It's related to clinical relevancy. You see here, all the question here, or the option here are antagonists. All muscarinic antagonists can be used, but they found it the most clinically relevant one to be scopolamine.
Atropine is sympathomimetic as well. So when we have activation of sympathomimetic, the salivation is going to reduce when we activate the sympathetic system, right?
Yes, correct. Yes. Yeah, I think the other doctor was confused. Doctor, I'm giving you other example. So in other
that's what I'm asking.
yeah, in other example, patient is going to do dental treatment and he has hypersalivation, and you have the same option. It will be atropine. Why? Because like it's the same way of action theoretically, but they found atropine to be more effective in this situation.
Okay, yeah, I got it now. Thank you, doctor.
You're welcome. So from a theoretical aspect, correct. You see, the answer is theoretical aspect is correct, but like from clinical perspective, no. Which of the following is correct regarding adrenergic neurotransmission? Epinephrine is the major neurotransmitter released from the synaptic nerve terminal. You remember I told you about this one? No, this is the norepinephrine. Norepinephrine is mainly released from the adrenal gland. So if you switch it, so norepinephrine from neurotransmitter, synaptic, and epinephrine on from the adrenal gland. Tricyclic antidepressant and cocaine prevent reuptake of norepinephrine in the nerve terminal, which is correct. MAO convert dopamine to norepinephrine in the nerve terminal. No, MAO converting the other, not the dopamine. Let's see now. Let's see the answer. So tricyclic antidepressant and cocaine inhibit the transport protein that prevent the reuptake of norepinephrine into the synaptic nerve terminal. Norepinephrine, not epinephrine, is a major neurotransmitter released from the nerve synaptic terminals. And epinephrine is mainly released from the adrenal gland. Finally, dopamine is converted to norepinephrine by dopamine beta hydroxylase and not by the MAO. Okay? So this like enzyme to break which neurotransmitter is easy, but like with time you are going to deal. Acetylcholine, esterase. Epinephrine, norepinephrine, MAO. Dopamine is related to dopamine beta hydroxylase, which we are going to discuss in depth in the CNS chapter. Also, at the end, I will explain about the full lecture released. It's available now on the website, but I will give you like a map how to deal with it. Okay.
Now it's blocked the reuptake to the vessel from synapse, right?
Yes,
Mal and comp.
but it's acting, and I'm not over the dopamine.
Yeah.
Okay. So here, epinephrine instead of epinephrine, and tricyclic and cocaine is correct. Moreover, information here, as we discussed before, cocaine is really dangerous medication. It's LA by its physical properties, like and the theoretical way of acting. But like if patient taking cocaine in last 24 hours, you cannot give him anesthesia with epinephrine. Okay. Hypertensive patient was accidentally given an alpha 2 agonist. Yeah, I think this is the question the doctor is asking about that irreversible, reversible. Was accidentally given alpha 2 agonist instead of alpha 1 blocker. Which of the following correct is this in this situation? So when you, again, the mainstream, and this is correct, is not wrong information, mainstream of agonist of thymostatic, it will lead to hypertension, but the only exception here is alpha 2. Okay? Alpha 2 agonists can increase the release of norepinephrine from the synaptic nerve terminal. I don't think so. Alpha 2 agonists can reduce blood pressure in this patient, and this is the weird information, which is clonidine. Alpha 2 agonists can increase blood pressure in this patient, no, if it's like alpha 1. Alpha 2 agonists will not affect blood pressure in this patient. This is not correct because alpha 2 is working to antagonist the action of alpha 1 through the decrease of level of norepinephrine and decrease of level of acetylcholine, which will like block the whole system from the beginning. Okay. Alpha 2 agonists activate alpha 2 receptor located in the presynaptic terminal of the sympathetic neurons and cause reduction in release of norepinephrine from synaptic nerve terminal. This leads to reduction in the blood pressure. Alpha 2 agonists such as clonidine and methyl dopa are therefore used as antihypertensive agent. Again, clinically relevant, no one uses it. It's used only in emergency, but this is like the weird information from the sympathetic system. Clonidine and methyl dopa. Okay, alpha 2 agonists can reduce blood pressure in this patient. A new antihypertensive drug was tested in an animal model of hypertension. The drug, when given alone, reduced blood pressure in the animal. So we established the drug is antihypertensive. Okay. Norepinephrine, when given in the presence of this drug, didn't cause any significant change in blood pressure or heart rate in this animal. So from this proven information or given information, so we know the drug is reducing the blood pressure. And to confirm it's working over something, we give him norepinephrine. So norepinephrine didn't work. So what do you think the drug is doing? The new drug is similar to which of the following drug in terms of its pharmacological mechanism of action? Prazosin, excuse me?
Sorry, Colonel.
I didn't hear. Say it again, doctor.
No, I'm saying clonidine.
Yes, see. Okay. So we have prazosin, clonidine, propranolol, calvidinol. So when you see the question, so I love this question because I will give you a way to think about it. So this is long question, clinical question, and you don't have the information. So you need to read it again so to get the information. So the question telling you we have antihypertensive drug which is working. We're telling you the drug is working. And then to see how the drug does it work inside of this rat or this animal we are going to test it, we give him norepinephrine. So when we give him norepinephrine, didn't cause any significant change in blood pressure or heart rate. So the new drug is working over which medication? So let's discard the question, read the option. Prazosin is alpha 1 blocker. Clonidine is alpha 2 blocker. Propranolol is beta non-selective blocker, beta 1, beta 2. Carvedilol is mixed alpha 1, beta 1, beta 2. So here norepinephrine is not working. So let's read the answer to conclude it. So norepinephrine activate both alpha 1 and beta 1 receptor and cause increase in heart rate and blood pressure. A drug that prevents the increase in blood pressure caused by norepinephrine should be similar to carvedilol that antagonize both alpha 1 and beta 1 receptor. So it's not related to beta 2 because like we give him norepinephrine and norepinephrine is not working. Why? Because norepinephrine is activating alpha 1, alpha 2, beta 1. So, and these receptors are blocked by which medication? Carvedilol, which is acting as antagonist to block all these three receptors. Prazosin is only alpha 1 antagonist. Clonidine is alpha 2 agonist, which is act other way to be antihypertensive medication. And propranolol or allol family is beta agonist and antagonist, sorry. And these drugs cannot completely prevent the cardiovascular effect of norepinephrine. So very weird question and very long question, but like when you break it down and you see it, you're gonna know how to solve it. Okay? And trust me, in the exam you will see such questions. But again, I don't want you to freak out. This is the minimal question. Like out of 10 questions, you may see 1 or 2 questions from this weird way of thinking. Don't freak out. Just read it, break it down, and break down the medication. So I'm telling you again and again, the solid knowledge of which every medication mechanism of action is critically and extremely important for you. I cannot train you for all the drug-drug interaction in the world. What can I do? I can train you to understand the mechanism of action of each drug. This way, in the exam, you will going to use your knowledge, your judgment to apply over it. And again, this is very minimal question. You will see maybe 4 questions in the whole 200 question coming from this weird perspective. Okay? Doctor, did you understand the concept and the answer here?
No. Can you explain it, please, again?
Okay. So
Why carvedilol?
we have a medication here which is reducing blood pressure. And when we give norepinephrine, so let's break it down. Norepinephrine, which receptors is activated by norepinephrine?
All of them except beta 2.
So which medication out of these 4 is working over these 3 receptors?
Carvedilol.
That's it.
Tricky.
See, I know it's tricky. Yes, I know it's tricky. I'm not saying it's easy question, but that's it. So the question is asking you norepinephrine is working over which receptors? That's it.
Okay. Another word, yeah?
Yes, that's it. They play over, like English is our second language. You are stressed in the exam. You see long question, you freak out, and that's it. So don't freak out. In the exam, trust me. The like my humble advice for you, NDB is freaking us out. Do not be freaked out in the exam. If I told you about my journey during this NDB process, the most important part not to freak out. When you freak out, everything will be ruined. I did a lot of horrible mistake in my practical exam, but I didn't freak out. When you don't freak out, it's easy. Okay?
Yeah.
Okay. Which describe the mechanism of action of male neuron and the heart failure. So this is the, like after hard question, I'm giving you a very easy question. So this is the way you're gonna see it. It's very hard question and very easy question. So this is the mode of action of male neuron and heart failure. Decrease intracellular calcium, increase cardiac contractility, decrease cyclic AMP, activate phosphodiesterase. So milneuron is working this way. Milneuron is phosphodiesterase inhibitor that lead to increase in cyclic AMP, increase intracellular calcium, and therefore increase contractility. So let's explain it in this diagram. So milneuron, as you can see in this diagram, is working intracellular, is working over the cyclic AMP. So cyclic AMP is critical for muscle to contract. Why? Because it has mechanism to lead to more calcium coming inside the cell. So cyclic AMP is converted to AMP. Milneuron is phosphodiesterase inhibitor, means it will block the conversion of cyclic AMP to AMP. So you have more cyclic AMP, which lead to more calcium inside the muscle, which will lead to more contraction, and that's it. Again, this type of medication which is working intracellular, like milneuron here, you will see it not ever prescribed as oral medication. It will be IV, it will be IM, it will be only in emergency situation because it has a lot of side effect and a lot of drug-drug interaction. So milneuron and dobutamine we discussed before to be the emergency medication to deal with hypertension. When patient goes home, we are going to give him digitalis or digoxin. Okay. So here it's working by increased cardiac contractility. The other option is the other way. Decrease, no, it's increase. Decrease cyclic AMP, no, increase. Activate phosphodiesterase, no, it's inhibit this one to lead to more cyclic AMP inside your muscles. Finally, last question. 60 years old woman had a myocardial infarction. Which of the following should be used to prevent life threatening arrhythmia that can occur post myocardial infarction in this patient? Digoxin, phelicindine, metropinolol, and broconamide. So this patient has myocardial infarction, and we want to give her medication to control it. So which is the golden medication in Canada? Yes, propranolol. Beta blocker, such as metoprolol, prevent arrhythmia that occurs subsequent to a myocardial infarction. None of other drug has shown to be effective in preventing post-myocardial arrhythmia. So the other medication can be used for this patient, but here asking you specifically for arrhythmia. So metoprolol or alol families, which is beta blocker, can be used as anti-arrhythmic drugs. Alol family, you will love it. You will see it everywhere. So Alol and T3 is the type of medication every medical doctor in Canada is prescribing. Okay, doctors? Okay. I don't want you to be intimidated with the question. These questions are really difficult and testing you in more than one aspect about the direct knowledge of the medication, about theoretical knowledge of the medication. Don't freak out about it. This is I received this feedback and I was shocked honestly because like I don't want you to think yeah this is so difficult. No, this is not so difficult. I would like you to be exposed to real question from day one. I will give you access for the practice question to see it, and I will do the WhatsApp group so you can communicate with each other, and I will give you access for the study sets, and I will make a short video to explain about study sets and how you can make the maximum benefit of it. Okay?
Those type of questions, they are on the website. We can access them.
This question is yeah. After each video, you will see questions. So, and this one is the quiz. So this 10 question you will see it as a quiz. So it's called
Okay.
weekly quiz one. You will see the question, you will see the answer, you will see everything.
Okay, okay, thank you.
You're welcome. So in this week we have 4 lectures, which is really important and really heavy. First we have hemostasis one, and then antimicrobial, antibiotic, antifungal, antiviral, and then we have CNS condition, and then ending up by sedative. 4 lecture are really heavy. Please, specifically the CNS one. Humble advice: if you miss lecture number 2 for CNS basic, do not do not even try to watch number 7 because number 7 is completely application of number 2. So please watch number 2 again and go for number 7 for you to be easier. The most important information in this lectures: anti-inflammatory, anti-platelet, anticoagulant medication, antibiotic medication, and barbiturates. This is like if you wanna like be super selective. This is the 4 topics you cannot miss from these 4 lectures. Again, I'm going to release the quiz maybe Tuesday or Wednesday. It will be only 10 questions. Let's make it 10 question, 10 question till we warm up. Everything is good. We're going to increase it. And that's everything for today. I'm going also to post a link for the one-to-one session. I promised you about it. Like it will be one-to-one for each one of you, so we can discuss each topic with us one-to-one. So because I know some people like are like not very familiar with asking question in front of everyone. Please send me any feedback you see in the lecture and the rhythm of the lecture itself, and I will do my best to fix it as soon as I could. Okay, doctors?
Doctor, I have a question. According to your experience,
Yes.
what about like I know like the first step in going to the pharmacology will be the most hardest, and it is like heavy on my heart to be honest.
Yes.
But because in back like in back days in the college period, I didn't also like, even though like I hate the straight A's in pharmacology, although that, but I hate it
Yes.
to be honest. I don't like it that much.
Yes.
But like what's like the most advice, or I don't even know why we have also started with the pharmacology, because I know it's a heavy topic, so maybe like it's in the first like line of the canon, so we have to ace it first, and then like we have the other topics which we are familiar in our clinical days, like the restorations, endo, all of that will be more easy. What's like the purpose in make it like in the first
Okay,
topic.
yeah, so let me explain first the second part and then I'll go to the first part. So, understanding of pharmacology will make medical management easy, will make LA local anesthesia easy. And in the real exam, there are the three main topics you are going to be asked: pharma, oral pathology, management. These three topics, you will see most likely the exam coming from these three topics. So, first of all, it's critically important for the exam. Second, it's very important for medical management because discussing about medical management and medication to deal with emergency without understanding how the medication is working will be very difficult. Like if I'm telling you nitroglycerin for angina or MI and you don't know how nitroglycerin is working, it will be very difficult to grasp the information. So this is why we start with pharmacology. I cannot deny pharmacology is very difficult and it's hard to understand. But what I'm trying to do during this one, I'm trying to give you the solid knowledge and telling you the critically important, the most important information that you need to know. So the most important information: each medication, mode of action, indication, one contraindication. That's it. If you going to do it study this way, you have 230 medication. This is the way I'm going to ask you to study each medication. When I'm telling you ibuprofen, so you know what does it, how does it work, when it's indicated, when it's contraindicated. When I'm telling you Melniron, which is like not very common medication, at least you know. When I'm telling you carbamazepine, you know it's used for this medication, used for this condition, not used for this condition, contraindication. So this is the minimal information I would like you to understand and grasp. Moreover, why we start with it? Because you have the longest time from this till the exam to study it. Because like if I'm giving you pharmacology just before the exam, first of all it will make it harder to understand the medical management, and secondly you don't have enough time to memorize all this information. You understand me, Dr. Ahmed?
Yeah, makes sense right now.
Same for pathology. Pathology is, it's painful, it's so painful just to make the lecture for pathology.
The oral,
But
the oral
again,
pathology is sectioned 3 times. Yeah.
yeah, but again, this is asked a lot in the exam, so I would like to give it before. Again, I constructed this way. Maybe I'm not correct. Maybe we're gonna adjust it next time. But like the last two, three topics, like ortho, implant, is not to be asked a lot in the exam. And ortho and implant, what you need to memorize a lot about ortho and implant? Nothing. Like it's information you need to know, and then you go to exam, and that's it. But if I give you pharma, pathology at the end, trust me, it will be a nightmare. And the more you go closer to the exam, the more stress you will have. So I would like you to have knowledge. You understand pharma, you know medical management, you memorizing pathology again, and then you build up. Because this is the three topics. It's really, really important in the exam. Other topics like ortho, epidemiology, implant, it's asked in the exam. But like if I want to discuss implant with you, you are going to see maybe two, three lecture and that's it. But for pharma, it's heavy. It's super heavy subject. Okay.
Yeah, makes sense, doctor.
I hope you like it. Maybe from next cycle, maybe we can give you option. But I'm just giving you a justification how I think about it. And because like we're studying today for the AFK exam, so we should construct everything to be relevant to the AFK exam. Correct?
Yeah, doctor, appreciate it.
You're welcome. Okay. Any more questions?
I have a question about you mentioned the paper type when you do the exam. You have two options, right? Biometric and paper.
Yes.
What's your advice? Which one we should take?
Um, so I did both. I can like for myself. Short answer: I recommend paper based, but it has like to do with your style of studying. So I short answer: I recommend paper based. Okay, but it's not like because like when you book the exam, most likely you will not have the luxury to pick. You are just picking whatever you see. So let's break down about the difference between paper and prometric. So each one of both has some downside and good side. So let's start with paper. Paper is natural, so we study with paper based all of our life. Like most of us did study paper from the beginning, but the paper has two problems. First problem, and this is very common. I see some people like, and this is honestly drive me crazy. I hope none of you doing this. He is solving the question inside the question sheet, and then after solving 10 question, he's transferring the answer to the answer sheet. please don't do this. You have like 100 possibility to ruin all your exam. If you shift one question, you are done. If you are moving the answer from the question sheet to answer sheet and you shift one question, done. Your exam is done. Secondly, sometimes, and this happened, trust me, with someone I know, she got 74, and she failed the exam because she didn't have time to transfer the last 10 questions. Think about it. She has the answer in the sheet and she didn't transfer it to the, think about it, 74. And she didn't give answer for the last 10 question. So please don't do this. You solve a question, you put it in the answer sheet. Second problem with it, some people reading question and then he read the question and it's so difficult, so his eye just skipping to the next question and then jumping to the previous question and jumping to the next question and going back 2 question back. So he's jumping like from one tree to other tree, which is not correct for your thinking during the exam. So what I recommend, you put your answer sheet over the question sheet and you read one question, you solve it, you put it in the answer sheet, you move, you move, you move. So there's a problem with
What if
paper.
I want to skip one? Like, it's long question. I want to leave it to the end.
Nice.
I should skip it, right?
Yeah, you can escape, but like in the answer sheet, you make a mark to be like very obvious that you.
Question mark.
Yes,
Oh,
yes.
yeah, okay.
In the answer sheet, please, in the answer, because like think about this.
We will have two sheets, like, draft and answer sheet.
No, you have one booklet for the question and one answer sheet.
Okay.
So let's give example. You are solving now in question.
Do we have a draft, like, to
No,
draft
you.
paper too?
No.
We don't have?
No, in the prometric, yes. In the paper based, no.
Oh my god.
Yes, in prometric you have, but like in the paper based, no. You have. You can write whatever you want in the question sheet.
We can do this.
Yeah, in the question sheet you can write whatever you want.
So I can check, like, the question, I'm sure about it. I can check it.
Yes, but like my humble advice here, like let's give an example. You are solving, and now at question number 8, you feel like this is long question. I will not solve it. I will come to it later. Okay, so you move to question number 9. If you don't make any mark over question number 8, so you will put question number 9 answer and the question number 8,
Yeah, I got it.
and that's it. If you do this, خلاص, done. So please don't do this. Don't do this. Okay. Prometric is like solving all these problems. So you see one question at a time. You cannot miss answer. Even if you didn't answer any question and you want to submit it, it will give you alarm that this question you didn't answer. So Prometric is lovely from this aspect. You cannot miss question. You cannot.
What's the downside for the Prometric then?
It's the feel of Prometric. Like it's you don't have paper to see the question. For myself, I read question and I decipher the information. So when I read like clinical question, like I write information. So he's telling you 7 years old with fracture over 1-1. So I write immature apex. So immature tooth, open apex. So this is how I saw. But like you can overcome this in the Prometric by writing in the draft sheet. They're giving you a lot of draft sheet. So you read the information. So this immature tooth, open apex, and then you move on. Patient with cardiac problem, you write cardiac. You know what I mean? Like this is the way you should solve the questions.
And you said, like, it's not my option to. It's not. I can't do it. Like, I can't choose which one I prefer more.
Theoretically,
I have to take.
no. Theoretically,
when I'm applying for the exam, do they give me that option, like, to choose between? Okay.
So theoretically, you will have option to pick. It will give you option on the screen. You will see like Edmonton, Toronto, Vancouver, and then you pick all these locations is paper based. Okay.
Oh, okay. So, okay, I got it.
And you will have one option for Prometric. So Prometric, you are not going to pick the Prometric center.
It's like a luxury.
Aha, correct. Yes. But the problem when you are booking, sometimes you don't have luxury to pick. You're gonna pick whatever you pick. So I see some people, they cannot find a location with a paper based one. So they say no, I'm not going to go to exam. I will book next time, which I don't think this is good way of thinking, because like you did a study, you wasted 6 months of your life to study. So I'm saying okay, I'm not going because it's only Prometric, or I'm not going because it's only paper based. No, each type of exam has its benefit, has its downside. So you should be smart. You should know how to deal with whatever you have. You understand me, Dr. Muhammad?
Yeah, yeah, okay.
So it's a different preference. For myself, I did both, and I liked more paper based because I like to write information. But like, if you are a kind of person you solve and then you move, or sometimes you don't solve questions. So for this, totally straight, go to parametric. If you are confused, you read question and you jump next question, you jump to previous question. For this type of person doing exam, no, please go to parametric. Do not even think about paper based. Do not even think about it. Go parametric because this will solve all these problems. Okay? Okay, doctors. Do you have any other?
Thank you, thank you.
Yeah, welcome. You're welcome, Habibi. So, do you have any other questions? Okay. Thank you, doctor, for everything. Thank you for joining.
Thank you.
I really see your hard work during the on the website. It's really make my day when I see like specifically last night I see all of you trying to make it and collect all the information before live session, and this is why I'm doing a live session because honestly the online course has some benefit if you having like luxury to go whenever you want, whatever you want, you can watch it like unlimited times. But at the same time you have this downside, no one is following up with me. This is why I'm doing the live session, and I'm going to do the one-to-one session to make sure everyone is following before the materials like goes up and up. Thank you very much, and see you next week same time for
Thank
the
you,
live session.
Doctor.
Yeah, welcome. Yeah, welcome. Thank you. Thank you. Have a good night. Thank you.
You too.
Thank you, doctors.